Okay, now comes the vasa previa. In case of vasa previa, what happens is, as you can see, the placenta is attached there. Okay, but instead of these vessels directly going into the fetus, what happens is these vessels will travel over the cervical os and then they enters into the fetus. Okay, so condition will be like, if this is your uterus, this is the placenta. Okay, now this placenta is attached to the uterus normally. Okay, but the vessels, instead of directly going into the fetus like that, and this is the fetus, for example. Okay, these vessels will travel first into the uterus and they will attach into the uterus. Okay, these vessels will first attach into the uterus, into the wall of the uterus. Then from there, the vessels again originate and they will then travel to the fetus. Okay, so these vessels, which are first attaching into the uterus, they will be covered with the Wharton jelly. And I hope you guys know about the Wharton's jelly.
Yeah, it covers the umbilical cord.
Yeah, it covers the umbilical cord, right? And it provides a protection to the umbilical cord. But now, because as you can see, only the this jelly is already present up to this part only. Okay, these vessels which are originating from this part of the uterus, they are all naked vessels. They are not covered with anything. Okay, and as you can see, let me clear this. Yeah, see this open. You have the placenta here. The placenta up to this point is covered with the Wharton jelly, but after this point, it is not covered by any kind of a jelly. Okay, and you call it a filamentous attachment. As you can see, this placenta is attached here, right? So it is not covered by any kind of this jelly. These vessels are naked, and as a result, they are very prone to rupture. They got rupture. It will cause the bleeding in the patient. It will be a painless bleeding again. But now, because the fetus cannot get a proper blood supply, what will happen? The fetal bradycardia, right? So this thing will help you differentiate between the placenta previa and the vasa previa. Both will have a painless vaginal bleeding. Okay, but in case of this placenta previa, and in case of the vasa previa, you will be having a fetal distress also. The bradycardia will be present. Okay, so in these conditions, the fetal vessels are located in the membrane, which is near the cervical os. Okay, and as a result, you will have an injury to these membranes. You will have a rupture there, and that will cause a painless vaginal bleeding. Okay.
Yes.
Now again, you can have the low-lying placenta in this condition. Doesn't matter. Okay, you can have the high-lying placenta or maybe a low-lying placenta, but the main thing is you'll be having a painless vaginal bleeding along with the fetal distress. The bradycardia will happen. Okay, and fetal death can also occur in these conditions. Okay, if you have a compromise and if you have a compressed labor, the patient can also this fetus can also die in this condition. So be careful with that. Okay, for diagnosis, you will perform this again the ultrasound. Okay, and that can show you the fetal vessels which are overlying the internal os. So if you know, and if this placenta is overlying the internal os of the cervix, we will call it a placenta previa. If the vessels are overlying this os, you will call it a vasa previa. Okay, in both the conditions, bleeding will be there. But if the fetal distress is there along with the bleeding, you will call it a vasa previa conditions. Please note these vessels are not covered by any kind of a Wharton jelly, and as a result, they will be at an increased risk of rupture, and that can cause the bleeding in the patient. Okay, so what would be the treatment? This treatment again will be the emergency delivery of the patient. And can you have a normal delivery in this condition?
No, right? Because when you're pushing out, you would be crushing the umbilical cord.
Exactly. You cannot have a normal delivery in this condition because, as you can see, these vessels are overlying cervical os. Okay, you cannot damage them, right? So the only thing you can do is the cesarean section. So emergency cesarean section will be indicated in these conditions. Okay. So this condition is associated with the filamentous umbilical cord insertion, where the umbilical cord is inserted in the chorioamniotic membrane, which is of course the amniotic sac, instead of the placenta directly, right? As you can see, this is the normal conditions. In these conditions, the placenta is here. Okay. And these vessels are attached here. You can see these these conditions here, right? So a fetal distress will be present because these vessels are unprotected by the Warthin's jelly. So they will have an increased risk of rupture, and that can cause the bleeding. Any doubt, please ask.
How do
No.
you get the high-lying versus low-lying placenta?
See, low-lying placenta is basically whenever they're present near the cervical os, we will call it a low-lying placenta. Okay. In case of this, the placenta previa, you will always have a low-lying placenta, as you can see, right?
Yeah, but is that usually just a result of inflammation or genetics?
See, when the fertilization occur, okay, and the zygote travels to the uterus, it can attach anywhere, right?
Yeah.
Most of the times, it attaches at the fundus or near the fallopian tubes. But sometimes, due to any condition, okay, this can be attached to the lower levels, right? And that can cause this condition. So it is not always defined that this zygote is always attached at the fundus. It can attach anywhere, right? But genetics or maybe some other environmental factors will contribute to that, and that can lead to the attachment at low levels. And when the attachment occurs at low level, when this just give me a second. When this implantation occurs at a very lower level, that can lead to these conditions, right?
Yeah. Okay.
So a history of any cesarean section, any history of this inflammation can do that. Any genetics can do that. Any kind of environmental factor can contribute to that condition, right?
Yeah. Okay.
Yeah, PID, endometritis. So just know how to differentiate between these three conditions: the abrupta placenta, placenta previa, and vasa previa. Again, whether the pain is present or not. If the pain is present, you will always go for the abrupta placenta. If the pain is not present, then check for the fetus these heart rates. Okay, and if the fetal distress is present, you will call it a vasa previa. If the fetal distress is not present, you will call it a placenta previa. Now, any doubt on any of these three conditions, please ask.
No, thank you.
Okay, so let's discuss the postpartum hemorrhage. See, as soon as the baby delivers, okay, and the placenta is also got delivered, okay, because you know that in the pregnancy, you're having a high clotting factors, right?
Yeah.
Very high levels of clotting factors because you need to coagulate the blood after delivery, right?
Yes.
Second thing you have is the oxytocin that causes the contractions because, for the wound healing, I told you in the general pathology, you will have a contraction of the wound, right?
Yeah.
Similarly, in order to stop the bleeding after this delivery, your uterus need to contract, and that could be done by the oxytocin again, right?
Right.
So by the action of the oxytocin and by the action of these clotting factors, you will have a decoagulation of the blood so that you cannot have the postpartum hemorrhage. But if any of these mechanism got failed, you will have something known as the postpartum hemorrhage. Okay, it could be due to a uterine atony. Okay, when the oxytocin is not working, you're not having any contractions. That can lead to the postpartum hemorrhage. Okay, it can happen because of any trauma. Okay, like if you have like if the patient is having any previous history of cesarean section, the uterine wall of the patient become very weak. And at the time of the delivery, because of this stretch and this stress, the patient can have a rupture of the uterus, and the rupture of uterus can cause the bleeding complications, right?
Yes.
If you lose the clotting factors, for example, the thrombin, in that case, again, you cannot have the clotting, and that can again lead to the postpartum hemorrhage. And I told you, if you have any kind of a radiant product of conception in the uterus, any kind of a fetal tissue or the placental tissue, you can again not have any contraction, you cannot have any coagulation, and that can again lead to the postpartum hemorrhage. So tone, trauma, thrombin, and tissue. These four things can lead to the postpartum hemorrhage. Okay. And when the uterus cannot contract after delivery, you will call it a bogey uterus. So this uterine atony, you will call it a bogey uterus. So step one can mention you a CV of a patient who is having a bogey uterus, and by the bogey uterus, they means that the uterus of the patient cannot contract. Okay.
Yeah.
Now, So what thing you should do after you encounter a case of a postpartum hemorrhage? Well, the very first thing you can give is the patient is the uterine massage. You will try to massage the uterus, okay, so that the vessels and so that the receptors can get activated and you can have a uterine contractions. If that thing doesn't help, if the uterine massage doesn't help, you will go for the oxytocin. You will inject the oxytocin inside the patient to get a uterine contraction. If again these things does not work, if you're still having a atony or even after the contraction you're not having any you're not able to stop this hemorrhage, what you will do is the surgical ligation of the uterine artery. And you guys already know that this uterine artery is a branch of internal iliac artery. So both the uterine artery and the iliac artery can be ligated in this condition to control the postpartum hemorrhage. And after ligating the uterine artery, you can have a ischemia or necrosis of the uterus, right? Because these vessels are providing these conditions, these areas, right?
Yeah, but
Yes.
the ovarian vessel is also supplying.
Yeah, exactly. But you have the collateral blood circulation, and that is by the ovarian arteries. And as anyone know, which artery branches is ovarian arteries?
Internal iliac.
Okay, any other option?
Inferior mesenteric.
Aorta.
Okay, once more. Any
Superior
other option?
vesicle.
Aorta.
Aorta, abdominal aorta, okay. All the
Oh,
gonadal vessels in males and females, they are both the branches of this abdominal aorta, right?
Yeah, yeah.
Okay, so they are the direct branch of the abdominal aorta. I see if you are blocking the, see, I told you, in case of this postpartum hemorrhage, you can either ligate the uterine artery or you can ligate the internal iliac artery. If the ovarian arteries are the branch of internal iliac artery and I'm ligating this artery, so how will I protect my uterus?
Right.
So please note that these ovarian vessels are the branch of abdominal aorta. So by blocking the uterine artery, you can still have these blood supply to these arteries, and you can have a total blood supply to the uterus now. Okay. So these three things you will do. First is the uterine massage. If that doesn't help, you will give the oxytocin. If that doesn't help, you will give the patient ligation therapy. Okay, you will give the patient this ligations of the uterine or the internal iliac artery, and the ovaries. So the sorry, just give me a second.
We also go for the tacking, like pressure.
These things can be done, but actually these are step 2 stuff, right? So I'm not going into that. Just a superficial stuff. Okay. So these three are the main things you will do. First the massage, then the oxytocin, and find the ligation. And in that conditions, the ovarian arteries will supply you. Okay, the step 1 will ask you this condition. Even if you're ligating the uterine vessels, why not you're having ischemia or necrosis of the uterus? And that's because of the ovarian vessels. Okay. Okay, and yeah, so how will you differentiate whether you are having the tonic condition or the traumatic condition or the thrombin conditions or the tissue conditions? How will you differentiate?
would you take a blood
Try.
sample?
Okay, I will take a blood sample for the thrombin, or maybe the patient can be having a history of any kind of a bleeding right before, maybe intercom bleeding, or maybe bleeding after normal trauma, right?
Yes.
Or a family history of bleeding could be there, right?
Yes.
So one thing is to look for the history of the patient. If they're having any previous history of bleeding complications, like a very severe bleeding after just a tooth and this extraction, right? Or maybe a gum bleeding, maybe a nose bleeding, or any family history of having a bleeding complications. So you can go for the thrombin conditions. What about the tone? Again, you can have this bogey uterus because of that. So you will say the patient is having a atony of the uterus. For the trauma, what things you should look for?
If your placenta was properly delivered, like the whole placenta was delivered.
Okay. And
If
I
you
mean, how a patient with a trauma, with this traumatic this postpartum hemorrhage will present you?
Previous
Would it be
history of
painful? Would it be painless?
it
painful.
would be less.
Okay, the one thing is a very painful condition it is. Second, what about the examination? The percussion of the patient maybe?
It would be very like a dense water.
Yeah, a gap may be there in the wall of the uterus, right? Because if you got a rupture of the uterus, there will be a gap in the wall, right?
Yeah.
So on the examination, you will find a gap in the uterus. A firm, a tender uterus will be present, right? Because it is a rupture condition. Okay. So if a very painful postpartum hemorrhage is present along with a firm tendrous uterus, okay, with a gap in the wall of the uterus, you will think about the lacerations or the incisions or the uterine rupture, right? What about the tissue?
The whole placenta wasn't delivered during pregnancy.
Yeah, you will be having a delivery of the placenta into pieces, right? The condition I told you, the morbidly adherent placenta. So look for these hints and they will help you determine whether it is a condition of a bogey uterus, whether it is a traumatic condition, whether it's a this coagulopathy condition, or whether it is a tissue condition. Okay. So look for these kind of hints. Step one can ask you these things also, why the patient is having a postpartum hemorrhage. So look for the history of the patient and you will know why this patient is having this condition. Okay. They will ask you what will be the next step you will do. Massage will be performed first. Then you will go for the oxytocin. And finally, you will go for the ligation. Okay. Now, any doubt, please ask on the postpartum hemorrhage.
When do we start giving medications as well?
What
Like,
medications?
to prevent the bleeding and to exacerbate the uterine contraction? We give like a
Yeah.
process.
Are you asking about the oxytocin?
Apart from the oxytocin, do we also give other prostaglandins?
You can give, no doubt, you can give that. Yeah. You can give these drugs also. I'm really not sure. Let me check. What is the treatment protocol for that? Just give me a second. Okay, so management will be given. First, you will monitor the vital signs and the urine output of the patient. Then the oxygenation therapy will be given. Okay. Then the ice packs will be given, fluid therapy, blood transfusions. Of course, if the bleeding loss is there, you need to give the patient the blood transfusions also. Then you will ligate the internal iliac artery or maybe the uterine artery. Okay. And suturing will be given. Hysterectomy could be given if and if the bleeding is not stopped. Okay.
Okay.
I think there is no mention of other drugs.
Okay. Okay. Thank you.
It's just the oxytocin, I think you're given just. Yeah. So the blood loss is there, so you need to give the patient these the blood transfusion also, and again the surgery thing will be given, the massages will be given, fluid management will be done, monitoring of the BP of the patient and the heart rate of the fetus. No, there is no mention of any other drug. Okay, I think just the oxytocin you will give.
Okay. Thank you.
And so again, and even after ligation, okay, you have ligated the vessels. Even if the bleeding is not stopped, then again in the very last you will give the patient hysterectomy, right? You will do the hysterectomy in the patient, remove the uterus, stop the bleeding, stop the life of the patient. Okay. At the very end, you will do the hysterectomy. Okay. Now you have the condition of ectopic pregnancy. Okay. In case of ectopic pregnancy, this is a normal condition. What happens is you're having a fertilization of the gametes here, zygote formation, and then you're having the implantation of the zygote either into the fundus area or into this area, right? But sometimes after the fertilization, the zygote implanted within the fallopian tube. And when the zygote implanted within the fallopian tube, you will call it a ectopic pregnancy. Now, because the fallopian tube is not ready for the implantation, not ready to conceive this pregnancy, because these areas are very weak, you will have a rupture of the fallopian tube with the pregnancy, with the ectopic pregnancy. And because of that rupture, you will be having a bleeding, right?
Yeah.
So that is the one thing. Now, because of rupture, you will also have pain, right?
Right.
And this implantation can be either on the right side and can be on the left side, unilateral. Yes.
Yeah.
So a patient presentation would be a unilateral sudden onset of severe abdominal pain along with the vaginal bleeding. Okay. A sudden severe onset of unilateral pelvic pain or lower abdominal pain along with the vaginal bleeding, you will think about the ectopic pregnancy. Now, I told you in the ovarian torsion, you're again having the unilateral pelvis or the abdominal pain, right? So how will you differentiate between the ectopic pregnancy and the ovarian torsion?
HCG,
Yeah.
beta HCG levels.
Okay. The one thing is the beta HCG levels that will perform, and what about the examination? Not the labs, but the examination. What we'll see?
Bleeding in ectopic pregnancy.
Exactly. You will have a bleeding in the ectopic pregnancy, but no bleeding will be seen in the ovarian torsion because you're having a collection of the blood in the ovary, right? In case of torsion, right? The
Right.
vessels are still intact. You're not having any bleeding. Okay. But in case of the ectopic pregnancy, because the fallopian tube is being ruptured, you will have a bleeding from the uterus and then to the vagina, right? So if the bleeding along with the unilateral lower abdominal pain or the pelvis pain is present, you will think about the ectopic pregnancy. But if a severe lower abdominal pain is present without any bleeding, you will think about the torsion. Is that okay? Now, other thing is you will have a rise in the HCG levels, okay, more than normal person, but again, less than a pregnant person, okay. The female will be having a low level of beta HCG, okay. If you do the ultrasound, you will again show a adnexal mass that is exactly seen in case of the torsion, right?
Yeah.
But in case of torsion, it would be an ovarian mass. In case of ectopic pregnancy, it will be an extra ovarian mass. So presence of an extra ovarian mass, presence of a beta HCG, which is of course low, but higher than a normal patient, non-pregnant patient, right? And the sudden severe onset of lower abdominal pain and a bleeding, these four things will be present in the ectopic pregnancy. Now, the other thing Stephen will ask you, what about if you take a biopsy of a patient from the uterus in case of ectopic pregnancy? What you will see on the biopsy of the patient?
Normal uterus.
Okay. How do you say it is normal?
Because implantation hasn't occurred and like it should be of secretory nature.
What findings you will see in the normal uterus in case of ectopic pregnancy?
Normal glands and vessels.
How normal? You have 3-4 phases, I told you.
Like the secretory phase.
Exactly. You will be in a secretory phase, right? Because if you're having a pregnancy, that means you're having a progesterone, right?
Yes.
And if you're having a progesterone, that will cause the secretory phase of this endometrium, right? You will be having a tortuous glands, coiled arteries, right? Edematous stroma.
Yes.
Yes. Because for the pregnancy, you require this progesterone. So because of the progesterone, you will be having a changes in the endometrium, and then changes will be the tortuous glands, the coiled arteries, edematous stroma, right? The secretory nature of the endometrium will be there, right?
Yes.
So if you perform the biopsy of a patient of a uterus, in case of the ectopic pregnancy, the placenta won't be there. You won't have any placenta. You won't have any placental tissue. Okay, no lacunae, nothing, because the placenta is in the fallopian tube. But you still can have a changes in the uterus, and the changes are exactly that you will see whenever you have this uterus in the secretory phase, because you need the uterus for the implantation. You have progesterone there, right? So we'll find the tortuous glands, coiled arteries, edematous stroma if you perform the biopsy of the patient. Okay. So risk factors will be the prior history of the ectopic pregnancy could be there. Okay, any history of the infertility will be there. And why this infertility will be important? Because infertility can also be happen because of the PID. If you're having a PID, that means you're having a scarring in the fallopian tube in the uterus, right?
Yes.
And if the scarring is present, the sperms can never reach to the ovum, right? Because you need cilia and other things to reach there. You cannot reach, right?
Yeah.
So the one thing could be the infertility. Now the other thing, even if the sperms reaches to the ovum and the scarring is present, that means cilia are not there, you can have the this implantation of this zygote within the fallopian tube because of the scarring, because of resistance now, right? So this zygote cannot move forward. So it will be implanted in the fallopian tube because of this scarring. So if the patient is having a previous history of gonorrhea, chlamydia, infertility, or PID, the patient can have a ectopic pregnancy risk, right?
Right.
Now, any ruptured appendicite, this appendix can also occur. Okay, this can lead to this ectopic pregnancy also because of the this inflammation again. Okay, any tubular ligation history will be there. Okay, smoking history can do that, and advanced maternal age. So these are all the risk factors for the ectopic pregnancy. Okay, if the patient just have a tubal surgery and now she got pregnant, so then they can have an ectopic pregnancy again shortly after this ligation. Okay.
Okay.
And what this surgery is known as?
Tubectomy.
Tubectomy, yes. Okay, so if you're having a patient who recently have a tubectomy, and now within week or two after tubectomy, patient started having this lower abdominal pain, ectopic pregnancy. So please note that this condition, the tubectomy, can also lead to the ectopic pregnancy because having a surgery in the fallopian tube, you can still have an ovum there, you can still have a sperms can reach to that conditions, right? You can still have a sperms reaching there, so you can have a fertilization, and that can again lead to the ectopic pregnancy, right? So this kind of a mass, as you can see, this is your the zygote, okay, and it is implanted within the fallopian tube, right? This thing will be seen.
Yeah.
Okay. Now, because of the blood loss, patient can also have the orthostatic hypotension again. Okay. So a patient sudden lower abdominal pain, vaginal bleeding, orthostatic hypotension. Okay, having an extra adnexal mass, extra ovarian adnexal mass in the ultrasound. Okay, and lower than the expected rise in the HCG levels. Of course, the beta CG is positive, pregnancy test is positive. You will think about the ectopic pregnancy. If you perform the biopsy of the endometrial tissue, you will see that dialed coiled glands, edematous stroma, coiled vessels. Okay, but the villi are absent because the placenta is in the fallopian tube, not in the uterus. Now, any doubt, please ask about the ectopic pregnancy.
No, thank you.
Okay, so what treatment you will give to the patient? Methotrexate. Okay, because this methotrexate will cause a termination of the pregnancy, right?
Yes.
So it will cause a death of the fetus, the death of the zygote, and that can prevent you from the ectopic pregnancy. So for the non-surgical treatment, you can give the patient this methotrexate, and that would only be given if you have a non-ruptured pregnancy. If you're just having a very slight abdominal pain, no bleeding, and you identified that the patient is having ectopic pregnancy, but is still not yet ruptured, you will give them the methotrexate to prevent this condition. But if you are having a ruptured pregnancy, in that case, you will only do the surgical treatment, okay?
Yes.
So these two things you should remember. If a non-ruptured, methotrexate. If it got ruptured, you will give the patient surgery. Again, any doubt, please ask.
No, thank you.
Okay, now you have the amniotic fluid abnormalities, the polyhydramnios and the oligohydramnios. We have discussed these conditions already. In the polyhydramnios, you're having too much of the amniotic fluid. In the oligohydramnios, you're having a little abnormal this amniotic fluid. Okay, it can happen whenever the fetus cannot swallow the amniotic fluid. Okay, that can be happen because of the esophageal atresia, the tracheoesophageal, these conditions we have discussed previously. Duodenal atresia can do that, and encephaly can do that. In all the conditions, fetus cannot swallow the abdominal fluid. Diabetes, anemia, multiple gestations can also do that. Okay. Second one is the oligohydramnios. When the fetus cannot secrete the amniotic fluid via urination, the patient can have a oligohydramnios. It could be due to a bilateral renal agenesis. It could be due to a posterior urethral valves. Okay, it could be due to any inability to excrete urine. Any case can do that. And whenever you have oligohydramnios, that can again lead to the port resectance. We've discussed that previously, right?
Yeah.
So that was a postpartum hemorrhage after placenta is delivered. What will happen? Uterine contractions will happen by the oxytocin. You will have a coagulation factor that will coagulate the blood there and prevent a hemorrhage. But if any of these mechanisms of fall failed, you will see the postpartum hemorrhage. Now, other most important thing is the amniotic fluid embolism. It is again a very rare condition, but very severe condition that happens shortly after the delivery. Okay, so it always happens when the baby is delivered. That is a very important thing to know. Okay, now what happens is the amniotic fluid, it contains the arachnoid metabolites, arachnoid acid metabolites, and that will activate your these factors, clotting factors, and that can lead to the DIC. And if you guys go back to the hematology, we have discussed that a very important cause of the DIC is the amniotic fluid embolism, right?
Yes.
So why this happened? Because this amniotic fluid metabolites will contain the arachnoid acids. And this arachnoid acid again can activate the clotting factors, and that can lead to the DIC in the patient. Okay. So it could be a case of any trauma. It could be any cesarean section of the patient. Okay, so a uterine rupture, any cesarean section, that can lead to the leakage of this amniotic fluid, a slight leakage of the amniotic fluid in the maternal circulation. And if that thing occurs, okay, then whenever this amniotic fluid enters into the maternal circulation, two things will happen. First thing, this fluid acts as an embolism. And now it can go anywhere into a systemic circulation, into your venous circulation, and can cause the embolism there, right? Second thing, this fluid contains the arachnoid acid metabolites that will activate the clotting factors, and that will cause the DIC in the patient. Okay, now this embolism will reach to your heart, to your lung, and there it can cause the respiratory distress, okay, and the cardiac distress in the patient, right? So this patient will be having a history of a chest pain because of the embolism in the lungs. Okay, she will be having a difficulty in the breathing shortly after the birth. Okay, the breath rate, the heart rate of the patient will be decreasing. Okay, the BP of the patient will be decreasing. Patient will be having a hypoxia because the embolism within the heart can do that. DIC is happening, so the patient will be having a bleeding from the incision sites, from the catheter, from the IV sites. Okay, ultimately cardiopulmonary arrest will happen and patient will die. Okay, so a cardiogenic shock, hypotension, hypoxemia, respiratory failure, coma, seizures. These 5 things you will see whenever you have a amniotic fluid embolism. That happens whenever a slight of the amniotic fluid leaked into the maternal circulation. That can trigger 2 things. One is the embolism, and second is the DIC. And embolism always reaches to the respiratory system. It can cause the respiratory distress. It can cause the cardiac distress in the patient. Shock can happen, right? So yeah, that was about the amniotic fluid embolism. Any doubt, please ask.
So the respiratory distress is causing the left heart failure?
Exactly. The pulmonary embolism, because it causes a main stem this blockage. Main stem artery got blocked, so you cannot move your blood forward, so you can have this shock. Or you can also have a cardiogenic shock again. Okay, that's why this low heart rate.
The cardiogenic shock?
Yeah, cardiogenic shock can also happen. Okay.
I'm asking what is triggering the cardiogenic shock?
Okay, what is triggering the cardiogenic shock? Well, this embolism, I'm really not sure what is triggering actually, but it happens because of this embolism. I'm really not sure about that.
Okay, I'm sure it's probably just a clot going into the coronary arteries or something. Okay.
Yeah, that thing can happen, yes. If the clot can enter the coronary arteries, and that can again lead to this cardiogenic shock. And the important thing is, if you perform the biopsy of the patient, because whenever you have an embolism and the patient dies, you will need to check the cause of the embolism, right?
Yes.
So when you perform the biopsy of this embolism, what you will find is the fetal squamous cells and the mucin. Okay, so if you got a patient who just died shortly after the birth, everything was normal before the birth, this patient will be having a normal delivery, a normal pregnancy, but shortly after this delivery, patient dies due to a respiratory arrest or maybe a cardiac arrest, having a low BP, low heart rate. Now you perform a biopsy of the patient of the lungs, and in the lungs, what you will find is the fetal squamous cells. And that's how you know that this condition is due to a amniotic fluid embolism. Okay,
Yes.
so that's about the amniotic fluid embolism. Now comes the herediform moles. It is nothing but just a swelling of the chorionic villi. And what is the chorionic villi?
The trophoblast which enters the.
Yeah, it is a trophoblast that is forming the villus-like structures, the syncytial trophoblast and the cytotrophoblast, right?
Yes.
Okay. Okay, and please note, in case of herediform these moles, you're only having the proliferation of the trophoblastic layer. I told you have two layers, the trophoblast and one is
Embryoblast.
embryoblast. So in case of herediform mole, you're only having the proliferation of trophoblast, not the embryoblast. Okay. Whenever you have a herediform mole, the patient will be having a vaginal bleeding. And please note, it is the first trimester vaginal bleeding. Before 20 weeks, it will happen. Okay. While if you're having a third trimester vaginal bleeding, you will think about the three causes I told you before: the placenta disabruption, okay, the vasa previa and the placenta previa, right?
Right.
So third trimester bleeding, think about these three conditions. If you're having a first trimester bleeding or any bleeding before 20 weeks, you will always think about the herediform mole. That is the first thing that should come into your mind. Okay. Patient will be having a emesis. Okay. You can also have a hyperemesis gravidarum where you have a severe vomiting in the first trimester. Patient will be having a uterine enlargement that is more than expected. That means it could be mimic as a polyhydramnios, right?
Yeah.
Because in case of polyhydramnios, you're again having a too much enlargement of the uterus of the patient than expected, right?
Right.
So how will you differentiate whether the patient is having a herediform mole or maybe a polyhydramnios?
Beta HCG.
Okay, both in these conditions, beta HCG could be positive.
Fundus height.
Yeah, fundus height. And what about the fundus height?
It should match up 1 centimeter per week. If you are like, if you've only been 12 weeks and you have like an 18 fundus height, you know that something is wrong.
Okay, and what about the polyhydramnios?
Could
In
you
both the
also
conditions,
an
yeah,
ultrasound?
okay, ultrasound can help. And well, not just go for the ultrasound. What about the examination? Just on the examination, on the history of the patient, gestation of the patient, what you will find?
Very, very nauseous, like more nauseous than normal. If you
Okay. See, whenever you encounter a patient with the herediform mole, please note that gestation weeks of the patient is always before 20 weeks. And that is a must thing. In case of polyhydramnios, you will diagnose it in a very later, okay? Like around 22 weeks, 25 weeks, right?
Okay.
You cannot have this the polyhydramnios at a very early stage of the pregnancy, right? In the first trimester, you cannot have that. Okay. So if you encounter a patient in the first trimester having these complications, urinary enlargement, vomiting, bleeding, you will think about the herediform mole only, no other diagnosis. While after that, after the first trimester, after 20 weeks, if you're seeing these conditions, then it could be due to other causes. Okay.
Okay.
So the weeks of the patient is very important. It will always be a patient of the first trimester or before 20 weeks, you can say. Okay. Beta HCG again will be positive and it will be very higher than what would be expected. Okay, because you're having a proliferation of the trophoblastic layers inside trophoblast. So they will release a very large amount of this the beta HCG. So a patient will be having a very high beta HCG. Because of that beta HCG level very high, okay, this beta HCG also promote the growth of the ovarian tissue, and that can lead to the thicker lutein cysts also. Okay, these cysts are very much common in the pregnancy also, but the number of the cysts is like 1 or 2. In case of a hyatiform mole, because you're having a too much level of beta HCG, that will cause too much cysts in the ovary. Okay. So along with having a hyatiform mole, patient can also have a multiple cysts in the ovary, and these are the thicker lutein cysts. Is that okay?
Yeah.
And why these thicker lutein cysts only? Why not the other kind of a cysts?
Because the corpus luteum is getting stimulated by beta HCG, and that forms the theca lutein cyst.
Okay. Why only thicker lutein cysts? That's what I'm asking actually.
Is it because you don't have that LH surge anymore because now you're in pregnancy?
What does this cyst mean? The thicker lutein cysts.
They make a
Because
lot of
Yeah. What do you imagine whenever you see this term, the thicker lutein cysts?
The corpus luteum, it is
Yes.
forming a cyst.
From the ovum.
Okay, from the ovum, from the follicle actually, you're having
Yes.
2 layers, right? The graphian and
Theca and granulosa.
yeah,
There-
exactly. In the graphian follicles, you're having a 2 layers. One is the theca externa, theca interna, and second one is the membrane granulosa cells, right? So in the theca layer, I told you that it is under the influence of LH, right?
Right.
And I told you that the alpha subunit of the HCG act as a LH, right?
Yeah.
So you don't have the corpus luteum still because you're not having the ovulation. Okay. But what happens is the remaining follicles in the ovary which are not yet matured, okay, they will be having a thicker layers. And in the influence of LH, which is basically the alpha subunit of this HCG, they will be stimulating the thicker layers to cause a cyst formation.
Yeah.
Okay, that's exactly what happens. So in the thicker lutein cyst, they're actually a cyst of the thicker layers of the follicles. Okay.
Yes.
Okay, so the hyatiform mole again, you will be having a swelling of the chorionic villi, and that will release more of the beta HCG or the HCG simply. This HCG will cause a thicker lutein cyst, and because of this increase in the HCG, patient will be having a very very large enlargement of the uterus, more than what could be expected to a patient. The patient will be having a vaginal bleeding. Patient will be having a vomiting emesis. Okay, and whenever you have an emesis in the first trimester, a severe emesis in the first trimester, you will always think about the hyatiform mole. And I told you this alpha subunit can also act as a TSH, right?
Right.
So the patient could also be having hyperthyroidism. Okay, and whenever you encounter this condition, you will perform the ultrasound of the patient. In the ultrasound, you will see these grapes-like appearances, these cysts-like appearance you will see. Okay, and whenever you see this kind of ultrasound, you will know that the patient is having a hyatiform mole. For that, you will perform the dilation and the curettage of the patient. In the dilation curettage, you will remove this hyatiform mole. Okay, you will give the patient methotrexate to end this fetal tissue completely if there is any. Okay, and then you will monitor the HCG level of the patient for any reoccurrence. Because you have removed this hyatiform mole, but you're still not sure if you remain any tissue right behind. So if any of the tissues remain behind, it can again give rise to the hyatiform mole, right?
Right.
To check this condition, you will always monitor the HCG level of the patient, okay, to check if there is a recurrence of the disease or not. So step 1 will ask you after the treatment of the patient, what should you do? You will always monitor the HCG levels of the patient. Now you have 2 types of moles. One is the complete mole and second is the partial moles. Okay, in case of a complete mole, It happens whenever two sperms fertilizes a ovum, okay, or no ovum is present, just two sperms fertilize together, or maybe a one sperm duplicate itself. So any of these conditions can lead to a 46XX or a 46XY condition. Okay, so whenever the two different sperms fertilize together without any ovum, it will be a 46XY condition. Whenever a single sperm fertilizes itself, it will be a 46XX condition, or 46YY also, right?
Right.
Majority of the time, even about 90% of the times, it will be a 46XX condition. So if the step one give you a patient with the hyatiform mole, and without giving any other hint, they're asking you what will be genetic of this mole, you will always answer 46XX because it is most common type. Okay.
Okay.
Okay, so whenever an enucleated egg or an egg without any nucleus meets with a single sperms that could duplicate its DNA, you will get a complete mole. In the histology, if you perform the histology of the patient of this mole, you will find the hydrophic villi. I told you are having the swelling, cystic swelling of the chorionic villi, right? So a swelling of the chorionic villi will see, and you will see the trophoblastic tissue proliferation, which is diffuse in the nature. Okay, throughout this mole, you will be having a trophoblastic tissue proliferation with the cystic swelling of this villus tissue. Is that okay?
Yes.
So a diffuse thing will be present. While when we discuss in the partial mole, you'll be having a focal cyst formation and the focal proliferation. Okay, so whenever you have a focal proliferation, think about the partial mole. If you are having a diffuse proliferation, okay, a diffuse swelling, diffuse cyst formation, you will think about the complete mole. Okay, fetal parts are not present because, as you can see, the egg is enucleated. Okay, so no fetal tissue is present. Okay, you have a P57 protein, and that protein only found if you have a maternal tissue in the fetus. In condition, in case of complete mole, okay, because this gene is parentally imprinted, and how this imprinting occur? How the imprinting occur? What mechanism is there?
DNA methylation.
DNA methylation. Yes. So this gene is basically parentally imprinted, and as a result, you will have a negative protein in case of complete mole because you have no maternal tissue, right? Beta HCG will be severely increased than what should be expected in this patient. See, in case of ectopic pregnancy, low levels of beta HCG, what would be expected? In case of hyatiform mole, a very high level of beta HCG. Uterine size will be very much increased. On the imaging, you will see the cluster of this grape appearance. As you can see, this kind of a snowstorm appearance you will see on the ultrasound of the patient. Okay, and the risk of invasive mole become 15 to 20%. Okay, and this condition can also increases the risk of choriocarcinoma by 2%. Okay, second one, you are having a partial mole where you are having both the male tissue as well as the female tissue. Okay, it could be a 69XXX condition, 69XXY condition, or 69XYY condition. Okay, so this condition is a polyploidy because you're having a complete extra set of chromosomes, right?
Right.
So this condition is a polyploidy conditions. Okay, because the fetal tissue is still present, the fetal parts are still present in this mole, you will be having only focal proliferation of the trophoblastic tissue. You're having a focal swelling, or the this hydrophic villi are only focally present at some areas only, while some areas are absolutely normal. Unlike in case of my complete mole, where I'm having a diffuse proliferation, diffuse cystic swellings, and diffuse all these things. Because a maternal tissue is present, the P57 will be positive. Okay, fetal parts are still present. Okay, HCG will be slightly increased. Okay, invasive mole risk is very much low, and the choriocarcinoma risk is very much low again. Okay, so if you encounter a patient having all these conditions before the first trimester, mainly, or before the 20 weeks, they are having the bleeding. Okay, they're having this hyperemesis gravidarum, right? They're having this hypothyroidism, or maybe cystic swellings in the ovary. Could be anything in the first trimester. You perform the ultrasound. You will see this kind of structures, the snowstorm appearance or the dilation of all these hydrophic villi. You perform the biopsy of the patient. You will see that on the biopsy you are having either a diffuse proliferation or maybe the focal proliferation, either the diffuse swelling or maybe the cystic or maybe the focal swelling. Okay, you will check for the P57 levels, you will find it negative or positive. And the beta HCG levels could be either very much increased or maybe normal. You will think about the having patient a complete mole or a partial mole. If the field tissue is present, it will be a partial mole. If the field tissue is not present, it will be a complete mole. Okay, now, any doubt, please ask.
What's the meaning of an invasive mole?
When you invade your layer of the this uterus, walls of the uterus, when it got invaded, just like a cancer,
Okay.
okay, you will call it an invasive mole. It will enter into the blood circulation of the patient also.
Okay.
Okay. And sometimes what happens is that within the first trimester, patient can also have a history of spontaneous tissue passing. Okay, it could be a patient who is still in the first trimester having a severely increased abdominal girth, this girth or a uterine enlargement is there, severe type. Okay, and she told you that she's having a history of spontaneous passage of a grape-like mass or maybe some kind of a tissue from the vagina in the first trimester only. Then immediately you will again think about the hyotiform mole. While she may not be having any of these conditions, emesis won't be there, bleeding could not be there, hyperthyroidism could not be there, okay, hyperemesis could not be there. But if they told you that the patient is having a passage of the tissue within the first trimester, you will always think about the hyotiform mole, okay?
Yeah.
So that was about the hyotiform mole. Any doubt, please ask.
No, thank you.
Okay, then let's take a short break and then again start the choriocarcinoma, okay? Okay, so choriocarcinoma is actually a tumor that arises from the trophoblastic tissue. So if this tumor is arising from the trophoblastic tissue, that means a cytophoblast and a cytophoblast. That means this cancer can only be occur after fertilization.
Right.
Right. So this tumor can only be occur whenever the fertilization occurs. Okay, so it can happen either at the time of pregnancy or after the pregnancy within a month uh, of the delivery. Right. It can happen both in the and it can happen both with the mama and as well as with the baby. Okay, so this tissue, this choriocarcinoma is actually a tumor of the trophoblastic tissue that can happen at the time of the pregnancy or after pregnancy, both to the mother as well as to the baby. It can happen to anyone. Okay, now because it is a tumor uh, uh, from this trophoblast, okay, that means inside trophoblast and a cytoplasm, that means there will be a disorganized growth will be there, right?
Right.
So if the disorganized growth will be there, that means these two layers cannot organize themselves into the villus structure.
Yeah.
So there will be no chorionic villi present because it is a disorganized growth. It is a cancer of these layers. So only the syncytophoblast and the cytophoblast is present, but no chorionic villi is present in this condition. Okay. Now, because these are the cancerous cells, they will release a very huge amount of beta HCG or simple HCG, right? So they will release the HCG. Patient will be having an abnormally increase in the levels of HCG. And whenever you have a high level of LCG, that will stay and these will stimulate, your thicker cells to release lots of this testosterone and androgens, and patient can also have the thicker lutein cysts present. Okay, so these patients will be having a multiple thicker lutein cysts in the ovary. They will be having an abnormally high level of beta HCG also, or a normal HCG, not just a beta HCG. Okay, both the alpha as well as beta. So a high level of HCG will be present. Okay, so it is a tumor of the trophoblastic tissue. It is highly malignant tumor. Please note that it is a very highly malignant tumor. It will early metastasis is present. Okay, it happens only after the fertilization and the implantation of the egg. Okay, now most of the cases are always occur whenever the patient has a history of hyotiform moles. Almost 50% of the times, patient will have a history of hyotiform mole whenever they are having a choriocarcinoma. Okay, almost 20-25% of times it happens when the patient is having a history of ectopic pregnancy. So it can happen with the hydriform mole, it can happen with the ectopic pregnancy, it can again happen with the normal pregnancy also 20% of the times. Okay, so no villi are present, only the cytoendocene site trophoblastic tissue is present. Okay, early metastasis has happened, and when the metastasis has happened, lung is the major site where the metastasis is. Okay, so symptoms will be the shortness of the breath or any kind of a respiratory difficulty will be present. So a clinical feature will be basically the thecal lutein cyst in the ovaries. Postpartum hemorrhage could be there, vaginal bleeding could be there. Okay, most of the times this condition is silent. Okay, and the symptoms are only occur when the metastasis happen. And because the major side of the metastasis is the lungs, so the patient will be having a respiratory distress, shortness of the breath, dyspnea, crackles could be there. So for that, you need to perform the X-ray of the patient. And when you perform the X-ray of the patient, as you can see on the first aid also, you will be having a cannonball metastasis. As you can see, these are the lesions of the cancers, and there appears as a balls, like, right? Multiple balls are there. So these are the cannonball appearance you will see. As you can see, these are all the balls-like appearance, right? These are the tumor cells or the tumor lesions, right? So that would, you call it a cannonball metastasis. Okay, multiple balls will be seen on the X-ray. So patient will be having a shortness of the breath, dyspnea, crackles could be there. You perform the X-ray, you find this condition. Now, this condition, along with a recent history of a pregnancy, okay, or maybe the patient is still pregnant, you will always think about the choriocarcinoma. Then you will perform the ultrasound of the pelvis. And on the ultrasound of the pelvis, what you will find is the multiple cysts in the ovary, right?
Yeah.
So thecal lutein cyst will be present. Okay, and again you will perform the dilation and the curettage. On the dilation and curettage, you will see the biopsy of the patient. Okay, so these are the diagnostic things you will perform: dilation and the curettage, beta HCG level, and this pelvic ultrasound could be done. Okay, now to remove the cancer, again you need to perform the dilation and the curettage. Okay, and you will remove it surgically. Okay, for the treatment of this cancer, you can give the patient methotrexate. Okay, so methotrexate is the first line therapy you will give for the treatment of the choriocarcinoma. Is that okay?
Yes.
And other treatment will be the hysterectomy. Of course, you can remove the entire uterus of the patient. That would again prevent the patient from having any this metastasis. Okay, and you need to again measure the levels of beta HCG for up to 12 months at least, in order to check for any kind of a reoccurrence of the tumor. Okay, so beta HCG is must. Okay, just like you check, in case of this hydriform mole, you need to also check the beta HCG in case of choriocarcinoma also. Okay, and yeah, that was all about the choriocarcinoma. So uterus, lungs, symptoms could be the postpartum thyroiditis could be there. Okay, because of the inflammation, because it can metastasis anywhere, right? This metastasis can happen anywhere, so patient can have these conditions. So abnormal vaginal bleeding will happen, uterine enlargement will happen, significant rise in the levels of beta HCG can also happen. Okay, and yeah, almost 50% of the times the patient could be having a history of molar pregnancy. Almost 25% of the times patient will be having a history of ectopic pregnancy. Okay, any doubt please ask about the choriocarcinoma?
Do we have symptoms of hyperthyroidism also? Like, can we have symptoms of hyperthyroidism?
Yeah, you can. Yeah, you can have the symptoms of the hyperthyroidism, no doubt, because you're having a high level of beta HCG or HCG normal, alpha beta both.
Yeah. Okay. Thanks.
So you can have that also. Any more doubt on this page?
No, thank you.
Now comes the hypertension in the pregnancy, and the first one is the gestational hypertension. Okay, whenever you encounter a patient having a blood pressure systolic more than 140 and diastolic more than 90, you will always call it a gestational hypertension. Now, this gestational hypertension occurs whenever you got the hypertension only after the pregnancy. Okay, so the patient won't be having any kind of a history before the pregnancy. Before the pregnancy, only after the pregnancy, patient will get the hypertension. Then only you will call it a gestational hypertension. Okay, and please note, just like in case of hypertensive urgency, remember you won't have any end organ damage, right?
Right.
But in case of preeclampsia, you're having a high BP along with the end organ damage. So BP without any damage, you call it a gestational hypertension, like a hypertensive urgency. While the preeclampsia will be having a hypertension along with the end organ damage. That means a hypertensive emergency, right? Right. So treatment of the gestational hypertension includes the hydralazine, alpha-methyl dopa, labetalol, nifedipine. Okay, that we have all discussed in the CVS also, right?
Yeah.
So that's about the gestational hypertension. Any doubt, please ask.
No, thank you.
Okay, so whenever you encounter a new patient, okay, a pregnant female of around 20 weeks, see, only after 20 weeks it can happen, right? Before 20 weeks, you will call it a molar pregnancy, right? Because it can happen only in the molar pregnancy before 20 weeks. Yes? Remember, I told you, hypertension, bleeding, emesis, anything, if it is happening before the 20 weeks, okay, you will think about the haitiform mole, okay? But when it happens after 20 weeks, then you will think about the other causes, okay?
Okay.
So the patient must be having a gestational age of at least 20 weeks in order to get a diagnosis of the gestational hypertension. Otherwise, you will first think about the haitiform mole. You will rule out that diagnosis. Only then again you can go back to these diagnoses, right?
Right.
But the first thing before 20 weeks, if it occurs, you will always think about the haitiform mole. Okay. So that's about gestational hypertension. You will get a female patient, a pregnant female patient of more than 20 weeks of gestation, and she is having a BP of more than 140 and 90. You will ask her whether she is having any other, other symptoms like a headache or maybe any other pain anywhere in the body. Okay, and if she denies for any kind of a pain or any symptom, then you will diagnose her with the gestational hypertension. Now, if she tell you that she is having a pain or maybe a proteinuria, maybe a headache, could be anything other than this hypertension in the pregnancy, then you will give her a diagnosis of preeclampsia. Okay, and for the preeclampsia, I want to remember just two things. One is the endothelial dysfunction, and second is the vasospasm. Whenever you heard about this term, the preeclampsia, you will only think about two things. One is the vasospasm, and second is the endothelial dysfunction. Now, how this thing happens? It happens because of the formation of abnormal placental spiral arteries. Now, because of this abnormal formation of the spiral arteries, you will have a hypoxia in the placenta. And as a result, the placenta will start secreting anti-angiogenic tissues or hormones and start decreasing, pro-angiogenic for these hormones. Okay, so all these hormones, all these neurotransmitters that form subvessels, that dilate subvessels, they will be decreasing, and the anti-angiogenic factors, all those who are causing the vasospasm or decreasing the angiogenesis, they will be increasing. Okay,
Okay.
and that will lead to the preeclampsia. So what happens is, it happens because of the abnormal development of the placental trophoblast and the spiral arteries. Okay, and that can again lead to the increase in the resistance. Okay, low resistance. In a normal condition, the placenta is very low resistance tissue, right? It will decrease the blood pressure. That's why. Okay. Now, in case of the preeclampsia, what happens is you will have a very high resistance in the placenta that will decrease the blood flow in the placenta and to the fetus. That will cause the hypoxia. Okay, you will be having a very high placental resistance. Because of that, the uteroplacental perfusion will be decreased. If the perfusion is decreased, you will be having a very low oxygen delivery. That will cause the fetal growth restrictions, right? Because of low oxygen in the blood. Okay, the patient could also be having the oligohydramnios, right? Is that okay up to here?
Yeah.
Now, all the pro-angiogenic factors will be decreased and the anti-angiogenic factors will be increasing. That is causing a widespread vasospasm throughout the body of the female. In every part, you will get a widespread vasospasm, right? Because of a damage of the endothelium, because of all these anti-angiogenic factors. Okay, you will be having a high level of all these non-epinephrine, epinephrine, low level of nitric oxide will be seen. That is again opposite to what you see in the normal pregnancy. In the normal pregnancy, you'll be having a high level of vasodilatory factors. Remember nitric oxide and other things.
Yeah.
Opposite is exactly what happening in the preeclampsia. A low level of nitric oxide will be seen, high level of this non-epinephrine, epinephrine will be seen. Okay, that will again damage all your endothelium. Okay, so a widespread vasoconstriction and ischemia will happen in the female. And because of this widespread vasospasm and the ischemia, the patient will be having a hypoxia to the other tissues, ischemia to other tissues, and as a result, end organ damage. Okay.
Yeah.
Now, incidence will be increased in the patients who are having any pre-existing history of hypertension. So it would be a patient having a history of hypertension, and now in the pregnancy, she's having a BP of more than 140/90 and having an end organ damage. You will diagnose her with the preeclampsia, right?
Right.
Patient could be having a history of diabetes. Okay, it could be a patient who is having a chronic kidney disease history, or maybe any autoimmune disorders like the antiphospholipid antibody syndrome. Now, because of this preeclampsia, because you're having a very low blood supply to the placenta, you can again have a placental abruption, right?
Right.
Because there's a low blood flow to the placenta can be detached from the wall of the uterus, and that can cause a abruptoplacentae. I told you you're having a, for the abruptoplacentae, the risk factor is the preeclampsia. If you guys go back, right? Coagulopathy can do that. Can be happen because of this abruptoplacentae again. Okay. Renal failure can also happen because you will having a protein urea in this condition because of a kidney damage that can lead to a renal failure. Okay. Because of the damage in the lungs, patient can be having a pulmonary edema. Uteroplacental insufficiency can occur that can lead to a fetal growth restrictions and oligohydramnios. And if the BP becomes severe and patient start having seizures, you will call it a eclampsia. So a preeclampsia with the seizures, you will call it a eclampsia, right?
Yes.
If this condition become even more severe and you're having a damage in the liver also, okay, and low platelet levels are there, you will call it a HELLP syndrome, HELLP syndrome, right?
Yeah.
Okay, so patient would be having a renal failure. That means the patient will be having a high creatinine count. Patient could be having a history of headache because of a damage in the vessels in the brain. Patient could be having a chest pain because and as well as a respiratory distress because of a damage in the lungs. Okay, so it could a symptom could be anything. Papilledema can also happen because of this high intracranial pressure. Okay, papilledema can also happen. Abdominal pain or maybe fatigue can also happen. So any symptom, anything, along with the blood pressure more than 140/90, you will always think about the preeclampsia. They will ask you specifically, what is the cause? What is the thing happening? So remember two things, endothelial dysfunction and the vasospasm. And that's again happening because of loss of the these angiogenic factors and an increase in the anti-angiogenic factors by the placenta. They all things will be released by the placenta only. Okay, a widespread vasospasm. Okay, and please note, because of that, fibrinoid necrosis can also happen. And if you go back to the general pathology part, we have discussed 3-4 causes only about this fibrinoid necrosis. One is the in CVS, what we have discussed about the vasculitis. And which vasculitis? Yeah.
All the vasculitis will be having fibrinoid.
No, not all the vasculitis.
Wagner's?
Yeah. Which vasculitis has the fibrinoid necrosis?
Polyarteritis nodosa.
Yeah, polyarteritis nodosa will have the this fibrinoid necrosis. Okay, that is the one. Second cause in the CVS again. Hypertensive emergency can cause it.
Right. Yeah.
You can either be having the hyperplastic arteriosclerosis or you will be having a fibrinoid necrosis, right?
Yes.
In the rheumatology, we have discussed one cause of this fibrinoid necrosis.
Giant cell arteritis?
No, in the giant cell arteritis, we will see the giant cells, right? Not the fibrinoid necrosis. See the name, giant cell arteritis. On the biopsy, you'll find the giant cells, right? Granulomas and the giant cells will be fine. In the rheumatology, we have discussed one cause.
Arthur's reaction.
not the Arthur's reaction. The rheumatoid nodules, remember, in the rheumatoid arthritis? If you perform the biopsy of these nodules, you will find the fibrinoid necrosis there. Okay. Open the page for the rheumatology, you will find it there. About the rheumatoid nodules, I told you will find the fibrinoid necrosis with the palisading histiocytes there. Open it, page number 466 in the first aid. You should know where they're located. Did you guys see it?
That page is missing.
466 in the rheumatoid arthritis and the osteoarthritis page.
Yeah, extra articular manifestations. in
Yeah,
rheumatoid
extra-articular,
nodules.
yeah. Extra-articular manifestations include the rheumatoid nodules, right? And see, it is written, fibrinoid necrosis you will find, right?
Yes.
Okay, so note all these causes of the fibrinoid necrosis. The one is the polyarthritis nodosa, second one is the malignant hypertension, third one is the rheumatoid nodules, and in case of your obscine, you will find the fibrinoid necrosis in the preeclampsia, okay?
Okay, yes.
So these are the four important causes of the fibrinoid necrosis that you must remember. Okay, any other cause? I don't think so. Let me check if I'm missing any other cause.
Do you have it in chronic graft rejection?
In the chronic graft rejection, fibrinoid, no. In that case, we'll be having the hypertrophy of the vessels that can cause the hypoxic changes.
Okay.
Okay, that is because of the hyperproliferation of these vessel walls and these inflammatory cells that will block the vessel ultimately, causing the atrophy and the hypoxic conditions in the gut tissue, right?
Okay. So that's more fibrosis, not fibrinoid.
Yeah, that will be the fibrosis.
Okay.
Let me check if I'm not missing anything. Give me a second. So preeclampsia, hypertensive emergency, vascular reactions. Yeah, that would be all about it. These four causes you must remember, okay, for the fibrinoid necrosis. Okay. So that you will find on the biopsy of the patient. If you perform the biopsy of the vessels, you will see the fibrinoid necrosis there. Okay, in the brain, you can have a headache, visual changes could be there. In the kidney, the protein urea will be there, very important. Okay, a new onset of hypertension, pulmonary edema, that means crackles, shortness of breath, dyspnea would be there. Okay, and brain, liver may, and the liver, you can have abdominal pain. Okay, in the right side of the abdomen, right upper quadrant, you will be having a pain. That will be the liver damage you can have in the preeclampsia. So whenever you encounter a patient having a high blood pressure, along a BP more than 140/90, along with any symptom, it could be any pain, any protein urea, anything it could be. Okay, a blurring of the vision, could be anything. You will always think about the preeclampsia. They will ask you why it is happening, because of the vasospasm, because of the endothelial dysfunction. Why this vasospasm and endothelial dysfunction happening? Because of the damage in the placenta that will be releasing the anti-angiogenic factors from the ischemic placenta will be having them, right? What if on the biopsy of the patient, you will see the fibrinoid and necrosis. Okay, causes or maybe the high risk factors include the having a previous history of the hypertension, diabetes, chronic kidney disease, autoimmune disorders can lead to that conditions. Complications, abruption can happen because of the ischemia, coagulopathies can happen, renal failure can happen because of a damage, pulmonary edema can happen, uteroplacental deficiency can just insufficiency can happen. It can lead to the eclampsia and to the HAL. Now, any doubt on the preeclampsia, please ask.
No, thank you.
Now, after the preeclampsia, you're having the eclampsia, and that is nothing but the preeclampsia with the maternal seizures. If the patient is having a history of the hypertension along with the and organ damage, and now the patient is started having the seizures, you will call it a eclampsia. Okay, maternal death in that condition can also happen because of the stroke. Okay, and intracranial hemorrhage can happen, or it can also lead to the ARDS. We will study what this ARDS is later in the respiratory part. Okay, it will cause a respiratory distress. It will cause the edema in the lungs, and that can again lead to death of the patient because of respiratory distress. A very severe condition, a very acute and severe condition this is. Okay, so that is about the eclampsia. Patient with the preeclampsia having a seizures, having a stroke, having a ARDS. Okay, treatment of it includes the magnesium sulfate, okay, antihypertensive agents, and immediate delivery is the important thing. Even if you give the patient magnesium sulfate or maybe the antihypertensive, they won't help much. Okay, the definitive treatment of the patient is the immediate delivery, because all of these conditions are happening because of the placenta, right?
Yeah.
Yes.
So if you remove the placenta, that will cause the revert back of all the changes, right? The symptoms will be over because of after that, right? So in both the conditions, preeclampsia and eclampsia, the definitive treatment is the delivery of the fetus. To remove the placenta, you need that. Okay. Then comes the HELP syndrome, and H stands for the the hemolysis. Okay. EL stands for the elevated liver enzymes. LP stands for the low platelets. Okay. So a patient having a history of preeclampsia, and now she's having a hemolysis, that means the anemia would be there. Okay, high ALT, AST counts will be there. Low platelets will be there. And ultimately, it can lead to the DIC of the patient. You will always think about the HELP syndrome. So a very severe form of the preeclampsia is the HELP. Patient will be having a bleeding from the IV sites, from the gums, from any incision sites. Patient will be having a subcapsular hematomas in the in the hepatic areas. Patient could be having a hypotension, hemolysis, low hemoglobin will be there, elevated liver enzymes, thrombocytopenia will be there. Okay, cystocytes will be seen, right? Because of the formation of microthrombi, so we'll find the cystocytes because of the DIC also. So that's about the HELP syndrome. What thing you will do is the immediate delivery again. Okay. Any doubt?
No, thank you.
Now you have the epidemiology for the gynecological tumors. Okay, in the United States, the most common tumor is the endometrial one. Second most common is the ovarian, and the third most common is the cervical. While in the world, cervical tumor is the most common, then the endometrial cancer, and then the ovarian cancer. Okay, so Stephen will ask you why this, this cervical cancer is least common in the US while it is most common in the other world.
Screening.
So it is because of the screening. Okay, it is because of the widespread vaccination and widespread screening. The cervical cancer is most common in the world, but not but the least common in the US because of the screening and vaccination. Well, the prognosis: cervical cancer has the best prognosis. Endometrial cancer has a middle type prognosis, and the ovarian cancer has the worst prognosis. Okay, so that's about the gynecological tumor epidemiology. So they will give you a patient who is dying because of any of these cancer, and while dying, she make a wish that all of her property should go to the charity to treat all the patients having a most common gynecological cancers. So then the Stephen will ask you to which tumor, to which kind of a patient all this fund should be going to. Okay, so it would be the endometrial cancer, right? Because it is the most common gynecological tumor, right?
Yeah.
So
Yeah.
that's how they will frame this question. So for that, you must remember what is the incidence of these type of cancers in the United States. If they ask you that all his property should be going into the charity to prevent the most common overall death in the females, so what it could be?
Ovarian.
Most common cause of death.
Cervical.
I'm not asking
Oh,
about any
okay.
tumor or anything. Overall, most common cause of death.
Cardiovascular.
Cardiovascular complications. Yes.
Cardiovascular.
Okay. In both the males as well as the females, the most common cause of death is the cardiovascular complications. So if they specify any tumor or any kind of a gynecological tumor or maybe any most common tumor, then you will check for that. If they ask you overall most common cause of death, then you will again answer that accordingly, right? So what is the most common tumor overall in females?
Breast cancer.
Yeah, breast cancer. And second most common?
Colon?
Colon is the least common one. Third most.
Lungs.
Lungs.
Lung
Yeah,
cancer.
lungs. Exactly, lungs. In males, what is the most common cancer?
Prostate.
Prostate. Second most common?
Lung.
Lung.
Again, lungs. And third most common?
Colorectal.
Colorectal again. Yes. So remember these three things. Okay. And what is the most common cause of death in child?
Accidents? Or sorry,
Accidents.
chromosomal abnormality.
Accidents. Okay. And what about the cancer? What is the most common cancer in the child?
Brain
Neuroblast-
cancer.
Think about that.
Brain cancer.
Okay. Second most common?
Blood.
Leukemias.
Leukemia. See, leukemias is the most common. Okay. Leukemias are the most common. Then comes the CNS tumors. Okay. And the least common, or maybe a third most common, you can say, are the neuroblastomas. Okay.
Okay.
Yeah, so that was about the cancer epidemiology that we have revised it again. Okay, so any doubts so far, please ask.
No, thank you.
Okay, now comes the vulvar pathologies. And the first one is the Bartholin cyst. Remember about the Bartholin glands?
Yeah.
What are the analogs of the Bartholin glands? Or the homologous organs? Yeah.
Bulbourethral.
Bulbourethral glands. And what structure they're arised of?
Urogenital sinus.
Yeah, urogenital sinus. Okay. So remember this. So you are having a pair of Bartholin glands on each side of the vagina. Okay. Now, if the duct of these glands are got blocked, then before the obstruction, you will always have the infection, right?
Right.
Because of increase in the pressure, low blood flow, again, you can have a infection that can lead to the inflammation, and that can lead to the Bartholin cyst and the abscess. Okay. You will have a swelling, as you can see. On the unilateral sides of the vagina, you will see this kind of a swelling. It could be a very painful, it could be a painless. Both could be there. Okay, most of the times it will be the tender mass. Okay, in the see, this is the anterior part and this is the posterior part. Okay,
Right.
this is anterior, this is posterior. So if they ask you where this mass is present, it will be on the posterior aspect of the vulva. Okay.
Yeah.
So it will be a unilateral mass present on the posterior aspect of the vulva or the vagina, right? It will be a very painful tender mass, occurs because of a blockage in the Bartholin gland duct that is causing, the inflammation and maybe the abscess, always seen in the reproductive age females. Now, any doubt, please ask. Simple condition, I think. Nothing much more complicated. No doubt.
No, thank you.
Now comes the lichen sclerosis. Okay. In this condition, you will be having a sclerosis of the dermis and the thinning of the epidermis. Similar thing you can see on other areas. In what condition?
Lichen planus.
No, not the lichen planus. A generalized condition that you will find the sclerosis of the dermis and the thinning of the epidermis. In the musculoskeletal, we have discussed.
Scleroderma.
Scleroderma, yes. In case of scleroderma also, you will be having a sclerosis or thickening of the dermis and the thinning of the epidermis, remember?
Yes.
So similar thing, if it is happening in the vulva, you will call it a lichen sclerosis. The patient will be having a thickening of the dermis, sclerosis or fibrosis. Because of deposition of all this collagen, you will be having a fibrosis. And thinning of the epidermis will be C. Okay. Erosions could be there. Whitish plaques could be there on the vulva, right? And it increases the risk of squamous cell carcinoma. Although it is a very benign conditions, but it still slightly increases the risk of this squamous cell carcinoma. Okay, any doubt? And please note that this condition only seen in the post-menopausal woman. So it will always be an old age patient, okay, that will present you with this condition. Okay, they will be having a whitish plaques on the vulva. A old age patient having a whitish plaques. They will mention that on the biopsy, you are seeing the dermis is very thickened, fibrosed or sclerosis, and thinning of the epidermis. You will always think about the lichen sclerosis. And they will ask you about this SCC. So please note that a slightly increased risk of SCC is present. So a cause of the squamous cell carcinoma in the old age is the lichen sclerosis. A cause of squamous cell carcinoma of the vulva in the young patient is the human papilloma virus. Okay.
Yes.
Any doubt, please ask.
No, thank you.
Okay. Now, again, you will be having a lichen simplex chronicus. Okay. In this condition, you will be having a hyperplasia of the squamous epithelium of the vulva. So you'll be having a very thick, a very leathery vulvar skin will be there. Okay. And this condition is very pruritic. So you'll be having a history of multiple rubbing and the scratching. So a chronic rubbing and scratching will be present. Thick leathery skin of the vulva would be there, as you can see. Okay. And all these scratches you can see here. Okay. So scratches, rubbing, thick vulva. Okay. Hyperplasia of the vulvar squamous epithelium. But please note that this condition is totally benign. It has no increased risk of squamous cell carcinoma. Okay.
Yes.
So that was the lichen simplex chronicus. In the lichen sclerosis, they will tell you that the skin is very parchment paper-like. Okay. So that thing again, they will mention in the lichen sclerosis, while the thickening leathery skin is seen in the lichen simplex chronicus. Okay.
Yes.
So that was about all these non-neoplastic conditions. Then you have the neoplastic conditions. That means the cancers. It could be two types. One is the vulvar cancer, and second, which is a squamous cell carcinoma, and second is the adenocarcinoma, which is the extra mammary pages disease. Okay. Now, in the vulvar carcinoma, which is most commonly a squamous cell carcinoma, and whenever you have a squamous cell carcinoma, what thing you will have on the gross examination of the patient? I told you the feature of squamous cell carcinoma generalized.
Keratin pearls.
What?
You said squamous cell carcinoma, right?
Yeah, it is squamous cell carcinoma. Yes.
Keratin pearl.
That will find the biopsy. I'm asking about the gross examination.
Very pink.
Okay, pink. Other thing, other important thing.
Bleeding vessels.
Okay, bleeding will be there first, and ulcers, right? Necrosis, ulcer. These are a very characteristic feature of this squamous cell carcinoma if it happen anywhere, right?
erythematous, fragile cells, vulnerable to bleed.
Yeah, so bleeding will be there, necrosis will be there, ulcerations will be there throughout the skin, you will find, right? So similarly, when you have a vulvar squamous cell carcinoma, you will have ulcerations on the vulva, right?
Yes.
Okay, so that is what you find on the cross examination. Now, other than that, patient can also have a leukoplakia, the whitish plaques that again you will see in the lichen sclerosis, right?
Yes.
So whitish plaques will be there, which is a leukoplakia. Ulcerations will be there. Bleeding will be there from that ulcers. On the biopsy, what you will find is the keratin pulse. Now, other than the keratin pulse, if you find the choleucytic changes, that means it is because of the human papilloma virus strain 16 and 18. Okay. While in a post-reproductive females, that means the post-menopausal women, it can happen because of the lichen sclerosis. Okay.
Yes.
So HPV-related causes includes HPV risk, of course, which means the multiple sexual partners could be there. Early coitage will be there. Okay, and it happens in the reproductive age females. In the non-HPV causes, which happens in the post-reproductive females, that means a females more than 70 years of age, they will be having a history of lichen sclerosis. Okay.
Yeah.
So that's about the vulva carcinoma. Then you have the yeah.
Sorry to interrupt. This leukoplakia is because of this herpes, or there is some other pathology behind this leukoplakia?
Hyperplasia, it's all because of the hyperplasia things. Whenever see, in case of tongue, remember you will have these whitish plaques again, the oral leukoplakia, remember?
Yeah.
So these are kinds of a precancerous lesions. You can think about them, like okay, the precancerous lesions there.
Yeah.
Okay, kind of a hyperplasia. Because of the hyperplasia, you're having these leukoplakias. Okay.
Thank you.
Now the second thing is the extra mammary Paget's disease, and you can again have a Paget's disease in the breast also, right?
Yeah.
Yeah.
And where other you will in other area, where would you find the Paget's disease?
Bone.
Bone. You can also have a bone, right? The Paget's disease of bone. So you can also have a Paget's disease of the vulva. Okay, and it happens because of the adenocarcinoma, intraepithelial adenocarcinoma it is. And please note, it is a carcinoma in situ. Okay, that means it will remain inside the epithelium only, it won't metastasize as often. Okay, and please note, unlike in case of my breast cancer, you won't be having any risk of underlying carcinoma, right? In case of breast, what actually happens is you have the carcinoma in the breast, and all these cells will travel through the ducts and reaches to the areola, right? And then it will cause a Paget's disease of breast. In this case, in case of extramammary Paget's disease, you won't be having any underlying carcinoma. This is a primary carcinoma you will see, and it is an adenocarcinoma. Okay, it will present you with the pruritus again, erythema will be present, crustings will be present, ulcers will be present. So all of these things are similar to that of vulvar carcinoma. So again, you need to differentiate between these two conditions. Okay, looking at the histology of the patient, you will see whether the patient is having a columnar cells or the glands, or the patient is having a creatine pulse, right?
Yes.
So that's about the extramammary Paget's disease. Both them can have a pruritus. Both of them can having the erythema, crustings, ulcers, necrosis, bleedings. In both the conditions, you can have that. So the biopsy is a definitive thing you can do, right? So any doubt, please ask.
No, thank you.
Okay. Then you have the condition of imperforate hymen. Okay. If the hymen is totally intact without any perforation, then the patient cannot have the leakage of the blood, right? At a time of this menstruation, the patient cannot have the menstrual blood flow, right? If the hymen is completely intact, right?
Right.
So these patients will be having a history of primary amenorrhea, although they are having a normal cycle. See, they have a proper normal cycle. With every cycle, they have the bleeding, but it's that the hymen is totally intact, and as a result, when this bleeding occur, they cannot see that, right? They have the collection of blood inside the vagina, inside the uterus, right?
Right.
So these patients, whenever you see a patient with the imperforated hymen, it will always be a teenager patient in the puberty, and she's complaining of the primary amenorrhea. Okay, it happens because of the incomplete degeneration of the central portion of the hymen. As a result, nothing can pass through it. Whenever the patient has the cycles, then with each cycle they have the bleeding, and all that blood will be stored in the uterus, in the vagina, right? So now,
Yeah.
because of the chronic storage or the accumulation of the blood in the uterus, patient will be having the hematocolpos. Okay, there will be the accumulation of the menstrual blood within the vagina. Now, as a result, because of this collection of the blood in the vagina, there will be a bulging in the hymen membrane. And this membrane, because the blood is present behind that, this membrane become very bluish, right?
Yes.
When you see on the examination of the patient, you will see a bulging membrane, which is very bluish. Okay. Now, because the blood is collecting in each cycle, the patient will also present you with the cyclic abdominal pain. At the time of the cycles where the patient should be having bleeding, instead of the bleeding, that patient will be having the abdominal pain. Okay.
Yeah.
Now, these kind of a child, they will of course will be asymptomatic until the menarche. When they start having the menstruations, that blood will start accumulating. And because of that accumulation, the patient will be having all these symptoms. Abdominal pain, cyclic abdominal pain will be there. Bulging of this hymen membrane will be there. Bluish hymen membrane will be there. Right? Patient won't be having any amenorrhea, right? The patient will be having a primary amenorrhea. They won't be having any bleeding till now. But the secondary sexual characteristics of the patients are totally normal because all the hormones, everything is totally normal in this patient, right?
Right.
Now, because all this blood is accumulating in the vagina, it will cause, palpable mass in the rectum also. Because of the bulging of the vagina into the rectum, patient can also have a palpable mass in the rectum. So whenever you encounter a teen patient who is having a history of amenorrhea and she is having a cyclic abdominal pain, you perform the examination of the patient. On the examination, what you find is a palpable mass in the rectum on the interior side. On the examination, you find a dilation, a kind of bulging structure from the vagina, a bluish bulging structure from the vagina. Patient is having a cyclic abdominal pain. Secondary sexual characteristics of the patients are totally normal. Okay, and the patient is having a primary amenorrhea. It will make you think about the imperforated hymen, right?
Yes.
Now, because of this imperforated hymen, at the time of intrauterine life, the patient is having a high estrogen level, right? So secretions can also be present in the intrauterine life because of this progesterone on this and this estrogen, right?
Could you
See,
repeat it?
estrogen is there, the progesterone is there. Same exactly what happens in the puberty. Okay, for the cycles, you require the estrogens and the progesterones, right? For a normal menstrual cycle, right?
Yes.
In the intrauterine life, you're having the estrogens, you're having the progesterone, right? So the secretions will be there from the uterus, right?
Yeah.
Now these secretions will again get accumulate in the vagina because of this imperforated hymen.
Right.
Because of this accumulation, at the time of birth, the patient can have the mucocolpus. Similarly to the hematocolpus, the patient can be having a mucocolpus, okay, which is a collection of mucus within the uterus, within the vagina, okay?
Yes.
So it could be a self-resolving bulging in the intrauterine life that you can see immediately after the birth, or this condition could be asymptomatic totally up to the menarche, okay?
Yeah.
So that's about the imperforated hymen. Just remember, just think about it. You're having no perforations in the hymen. It is totally intact. So you cannot have any blood flow through the vagina. So all this blood, all this mucus, all the secretions will be start accumulating inside it. And you will be having a symptoms, a mass symptoms mainly because of that. Okay. That's all about it.
Excuse me.
Yeah.
So when we call the primary amenorrhea or when we call the secondary amenorrhea, like because
When you have the menarche,
Yeah.
but now after the menarche, you have 3-4 cycles, you have 3-4 menstrual cycles with the bleeding. But now you stop the bleeding. Now you're having an amenorrhea. You will call it a secondary type. Okay.
Okay.
If you are a patient who is on the 16, 17, 18 years old, but still do not have any menarche yet now, you will call it a primary amenorrhea.
Oh,
Okay.
I was thinking just hormonal hypothalamic pituitary axis is one is called primary something.
Yeah, cause could be anything. Cause could be anything. Okay. If the patient still do not have any kind of a bleeding, you will call it a primary amenorrhea. If the patient previously has the bleeding, but now she is having a amenorrhea, you will call it a secondary type.
Mhm, mhm. Okay. Thank you.
Okay.
Thank you.
Yeah. So because and because this hymen is intact totally, it is not imperforated, right? It is it is not perforated. It is intact. So the patient, she still do not have any cycle yet now, right? Any bleeding yet now.
Yeah.
So that's why the primary amenorrhea.
Yeah. Okay. Thank you.
Now comes the vaginal tumors. Okay, so the most common one is the vaginal squamous cell carcinoma. Again, that happens because of the human papilloma virus. You will have the cholestatic changes. You will have the creatinine pulse, ulcers will be there, bleeding will be there, necrosis will be there in the vagina. Second, you have the clear cell adenocarcinoma, and I told you it will be seen in the patients who are on the DES therapy, right?
Right.
Because it will prevent, the metaplasia to the squamous cells from the columnar cells, right, in the in utero life.
Yeah.
Okay. The third one is the sarcoma botrytis, and it's happened only in the females who are less than 4 years old, and it is a tumor of the smooth muscles, skeletal muscles. We will call it a abdominal rhabdomyosarcoma. Okay, it is a myosarcoma, which is a tumor of muscles. Okay, the patient will be having a grape-like mass, okay, which is emerging from the vagina. So whenever you see this kind of a condition, you will always think about the sarcoma botrytis. Please note, females will be always less than 4 years of age, and because they are the tumors of muscles, they will be Desmin positive as well as the vimentin positive. Remember, vimentin.
Intermediate filaments.
Yeah, for every intermediate filament, for every mesenchymal tissue you will have a vimentin positive, right?
Yes.
For the muscles specifically, you will be a Desmin positive. So both the vimentin, Desmin positive in the muscles, right?
Yes.
And in all these conditions, we will stain the intermediate filaments in these cells. So any doubt, please ask.
No, thank you.
The ovarian torsion we have discussed previously. Any kind of a cancer, any kind of a mass in the ovary will cause a torsion of this ovary along the infundibulopelvic ligament or maybe the ovarian ligament. You will have a compromisation of the vessels. Accumulation of the blood will be seen in the ovary. You will be having an intra-ovarian this adnexial mass on the ultrasound. Painful unilateral abdominal pain, lower abdominal pain, or maybe the pelvic pain will be present. Now you have the condition which is the pelvic organ prolapse. This condition occurs with the multiple delivery history. When the patient has a delivery, when the patient is having a multiple delivery histories, okay, what happens is that the pelvic floor muscle of the patient become very much weak. That means the levator ani muscles or the pelvic floor muscles, they will become very much weak, and as a result, the herniation of the pelvic organs like the urinary bladder, rectum, vagina, right? All these things will get herniated, and that causes the pelvic organ prolapse. This condition will only seen in the old age patients having an age of more than 60 years of age, right? Okay, and this muscle could be this muscle could be damaged with any increase in the intra-abdominal pressure that happens because of the pregnancy, because of the obesity, happens because of the obstetric trauma. Okay, that means multiple forceps assisted vaginal delivery. The patient most commonly will have a history of multiple forceps assisted vaginal deliveries. As a result, the laxity of the pelvic floor muscles will increase, and you will be having a decreased organ support that causes the prolapse of the organs, right?
Yeah.
Now, if the rectocele is prolapsed, okay, due to the prolapse of the rectum, patient can have a blockage of the defecation. Now, if the pathway of the defecation is blocked, patient will be having an incomplete defecation or a history of constipation will be present. Okay, and that's because of a change in the rectal angle. UL has a very nice diagram for that. You will look for that. Okay, for the rectocele, UL has a very nice diagram for it. Okay, where they properly show how this prolapse will occur anteriorly, and as a result, you will have an accumulation of all this material inside the rectum, and as a result, the patient will be having an incomplete defecation and the constipation. Now, because of that, because of the accumulation of all this material inside the rectum, patient can have the mass symptoms also because of that, right?
Right.
When the rectum is expanding, it will herniate into the posterior vaginal wall, and that causes the rectocele. The patient will be having a bulging of the vagina out of the pelvis. Okay, so they will be having a feeling of bulge, that is something is falling out of the vagina, they will tell you. Okay, for the defecation, they need to do the splinting. Okay, they need to put the pressure against the vagina, against the prolapsed area of the vagina. They will put a pressure, and that thing will help them defecation. Okay, so they will have the history of splinting. That means a pressure against the prolapsed area that will help them improve defecation. The patient will be having a visible bulge in the vagina, and that bulge will be increased whenever they have an increase in the abdominal pressure. That means any kind of a straining, any kind of a Valsalva maneuver will cause an increased bulge into the vagina, right?
Yes.
So the patient will often compresses the vagina manually to get a bowel movement. That's what you see in the pelvic organ prolapse. Now, any doubt, please ask.
No, thank you.
So just think about the weakening of the pelvic floor muscles. All of these things are happening because of that only. Okay, the herniation, prolapse, posterior, anterior, and all these things. That's all because of the damage or weakening in the or laxity in the levator muscle complex. Then you have the cervical pathology. Okay, and that is the dysplasia and carcinoma in situ, of course. All these things, the cervical cancer happens because of the human papilloma virus. Okay, and please note that the human papilloma virus always infects the squamous cells. And what kind of squamous cells? The keratinized or non-keratinized?
Non-keratinized.
Stratified or not stratified?
Stratified.
Yeah, so it will always happen to a stratified non-keratinized squamous cell epithelium. Squamous epithelium. Okay. Now, please note that the stem cell layers lies in a very deep, right? And only the stem cells has the ability to replicate, to proliferate, right?
Right.
So the human papilloma virus will infect first the stem cells which are found in the basal layer, right?
Right.
So the cancer always start in the basal layer of the squamo-columnar junction, and that is a junction, in the cervix where the squamous cells are present and where the columnar cells are started, right?
Right.
So this cancer always begins in the basal layer, that means the stem cell layers of the squamo-columnar junction, because only these layers will have a potency of the differentiation or the replication, right?
Right.
So what actually happens is, let me draw this for you. You're having a basal layer, right? And this is the apex, let's say. You're having a lumen here, right? And this is the squamo-columnar junction. So the tumor starts first from the base of the layer, from this epithelium. Okay, these are the squamous cells, stem cells. So tumor starts here. It will start growing upward. Okay, these are all these cells now become very much with the involved in the cancer. So first it involves less than 1/3 of the total epithelium. Okay, you will call it a CIN1. As this tumor progresses, it will involve more than 1/3 area, going from base to the apex. Please note the direction of the growth, base to the apex. Okay.
Yes.
So now this tumor involves more than 1/3 of the area, and you will call it a CIN2. Okay, when more than 1/3, but it's still not complete. Okay, when the complete epithelium is involved, sorry, when the slightly less than the complete epithelium is involved, you will call it a CIN3. So more than 2/3, but less than the complete, you will call it a CIN3. When the complete epithelium is involved with the cancer, you will call it a carcinoma in situ. Okay.
Yeah.
And when the metastasis happens, that means when the cancerous cells invade the basement membrane, you will have a metastasis, and now you will call it a cervical cancer. Okay, a metastatic cervical cancer, you will call it, right?
Right.
Now this condition, it starts with a dysplasia. Okay, and I told you already about the dysplasia. What is it? What is the meaning of dysplasia?
Disordered cell growth.
Yeah, it is a disordered cell growth, you will see, right? You won't have any any defined nucleus-cytoplasmic ratio. You won't have any nuclear the polarity of the nucleus won't be there. The basal polarity which is seen normally, it won't be there. Cell size will be different, cell shape will be different, but still this condition is reversible if you treat this condition. And if you remove the virus till now by giving the patient therapies or something else, patient can still have the normal condition back to again, right? And they can revert back to normal conditions again, right? Because it is dysplasia. If you remove the stressor, you will have the normal thing again, right?
Right.
But if this condition is persisted, the patient will go into the CIN2, then to the CIN3, and finally patient will get the carcinoma in situ, and now this condition become irreversible. Okay.
Yes.
So that is the classification of the cervical cancer. Okay, start with the CIN1, cervical intraepithelial neoplasia 1, then CIT2, the CIN2, then the CIN3, and finally the carcinoma in situ. Sometimes the CIN3 is also known as the carcinoma in situ. In some textbooks, it is mentioned, while some considered it as a separate thing, while the carcinoma in situ is a different thing. Okay, so depending upon the extent of dysplasia, you will call it a CIN1, CIN2, or CIN3. Human papillomavirus 16 and 18 caused this condition, and you guys already know that the 16 and 18, they releases the E6 gene and the E7 gene. The E6 gene inhibits the TP53 and the E7 inhibits the RB, retinoblastoma, right?
Yeah.
So they're inhibiting the tumor suppressor genes, so they are causing the cancers. And when you perform the biopsy of the patient, okay, what you will find is the coilocytes, which are, as you can see, these are the nucleus of the cells, and you will have a perinuclear clearing. I hope you guys can appreciate that. Yeah, right? You're having
Yes.
this perinuclear clearing, and then you have this this kind of cytoplasm, right? On the periphery, you can see. So cytoplasm is seen in the periphery, as you can see on this cell also. This is a nucleus, a perinuclear clearing, and then the cytoplasm, right?
Right.
So these are the coilocytes you will see whenever you have a human papillomavirus infection. Not just the cancer, any infection with the human papillomavirus you can have the coilocytes, okay?
Yeah.
So when the patients, because they have the CIN, they will be asymptomatic, they won't have any symptom. Okay, so for every reproductive age female, you will perform a pap smear. Okay, you will take a sample from this scomocolumnar junction. Okay, you will analyze it, and you will find if the patient is having a coilocytes or not. If the patient is having a coilocytes, then you will take the biopsy of the patient. You will check for the dysplasia. If you find a dysplasia, if you find the DNA positive for the 16 and 18 strains, you will call it a CIN then. Okay.
Yeah.
Now, symptomatic patients, because most often times the condition is asymptomatic, but the symptomatic patients will always present with the post-coital bleeding. After the sex, they will have the vaginal bleeding. That is a post-coital bleeding, right? So this is the most common presentation of a female. So whenever you encounter a female, a reproductive age female, who is having a post-coital vaginal bleeding, you will always first perform the pap smear in her. Okay, you will check whether she is having a coilocytes or not. If she is having a coilocytes, you will perform the biopsy. In the biopsy, you will check for all these dysplasia things and the involvement of the epithelium. If you find it positive, you will call it a CIN1, CIN2, CIN3 accordingly, okay?
Yes.
Now, the multiple risk factors could be there, and all these risk factors are for the human papillomavirus. Patient could be having, the most important one is the HIV. Okay, whenever the patient having HIV, okay, you will always check, whenever you got a patient with the HPV infection, you will always first check for the HIV. Okay, because most of the patients with the HPV, they also have the HIV, right? So step one will ask you if you encounter a patient, any patient having an anal carcinoma, or maybe the vaginal carcinoma, maybe a cervical carcinoma with the human virus, you will first check for the HIV also, because most of the times if the patient is having a HPV, they will also be having a HIV, right?
Right.
So multiple sexual partners could be there, HPV could be there, smoking can cause this cancer. Okay, early coitus can cause it. If you have a sex before the age of 18 years, that means you're at a 2x risk, 2 times risk of cervical carcinoma than a normal person. Okay, so having this history of intercourse before the age of 18, that will put the patient on a risk of having a cervical cancer 2 times. Okay, DES exposure can cause it. Okay, any unprotected intercourse can cause it. Okay, HIV can cause it. Transplant, that means any history of immunocompromisation can cause it. Okay, because you need the T cells to respond against the human papillomavirus, right? In both the conditions, the transplant or HIV, you are removing the T cells, right?
Right.
So they cannot fight this infection, and as a result, you will be having a CIN1, CIN2, and CIN3. Now, any doubt, please ask.
No, thank you.
Okay, now after the carcinoma in situ, you will be having an invasive carcinoma. Again, it's commercial carcinoma, right? On the pap smear, you can detect a dysplasia before it progresses to the cancer, of course. That means, and that's why we do this screening, of course, to detect the dysplasia, not the cancer, right? That is the most important thing. Stephen will ask you. The pap smear always detects a dysplasia, not the cancer. Okay. Diagnosis is done via the colonoscopy or the biopsy. Of course, I told you whenever you find the abnormal pap smear, you will always perform the biopsy, and that is the definitive diagnosis you will perform. Okay. Now, sometimes what happens is, instead of involving the lower cervix, this condition can also infect the upper cervix, right?
Okay.
In that case, you cannot detect this condition with the pap smear. Okay, because in the pap smear, you take the biopsy from the scomocolumnar junction. If this condition is affecting the upper cervix, you cannot take a pap smear from there, right? Because you take this smear only from the scomocolumnar junction, and that junction is absolutely normal. So it will give you a false positive even sometimes. Okay.
Yeah. Okay.
So if you get a false positive in the patient, Stephen will ask you why this false positive is present. It is because instead of involving the lower cervix, okay, this condition is involving the upper cervix, and as a result, the pap smear cannot detect it. Okay.
Yeah. So we'll call it false negative, right?
Yeah, you will call it a false negative. Yes.
Okay.
Okay. Now, other thing is, you can also get a lateral invasion. Sorry, see, because it is a mass, right? It is a tumor. It is a mass in the cervix, right?
Yes.
So patient can also have a mass symptoms because of that once he got the cancer. And the mass symptoms can even compress the urinary bladder. They can compress the rectum because they're present just anterior to the rectum, right?
Right.
And posterior to my urinary bladder, right? So
Right.
this condition can even block the urinary bladder. This condition can block the rectum. And if it grow laterally, this condition can even block the ureters, right?
Right.
And that can again lead to the hydronephrosis. If you go back to the renal, we have discussed that the cervical cancer is a very important cause of the hydronephrosis because it blocks your ureters, right?
Yeah.
So that would be seen in the invasive carcinomas. Whenever they grow very large, it become a very large mass and an invasive mass that causing the mass symptoms. Okay, that's about your invasive carcinoma. Now, any doubts so far, please ask.
No, thank you.
Just give me a second. Okay. Yeah, now comes the primary ovarian insufficiency. Okay, and you call it a premature ovarian failure. Remember, you will get this the menopause before the age of 40 years, right?
Right.
So in case of a primary ovarian insufficiency, we'll get a menopause before the age of 40 years, or even or shortly after puberty, we'll get this condition again. It happens because of the premature atresia or the atrophy of the ovarian follicles. Okay, very important. It is most commonly idiopathic condition. Okay, and sometimes could be associated with the chromosomal abnormalities also. Autoimmune conditions can also do that. Whenever you got autoantibodies against the follicles, they will cause a damage in the follicles that will again cause the atresia of the follicles. You will get the primary ovarian insufficiency. Okay, and yeah, because of the ovarian insufficiency, patient will be having a low level of estrogen, high level of LH, high level of FSH. So a patient having a menopause before the age of 40 years, you will think about the primary ovarian insufficiency because of the atresia of the follicles. Nothing more complicated. Simple thing, okay? Find out.
No, thank you.
Okay, so in this condition, do the patient is having a primary amenorrhea or a secondary amenorrhea?
Secondary.
Secondary.
Secondary, yes, because they have the menarche, but after that the ovarian failure occur, and now they got this amenorrhea. So it will be a secondary amenorrhea patient will have. Okay. Now the other causes of the anovulation, okay, and the most common one is the pregnancy. Well, that is the important thing. Whenever you encounter a patient having a secondary amenorrhea, okay, you will always first test them for the pregnancy. You will check the pregnancy test, the serum pregnancy test you will run. If you get it negative, then only you will go for the other causes. You can appreciate that whenever you see any encounter a question in the U world for any kind of a secondary amenorrhea, then you will see in the clinical vignette of the patient, they will always mention that the pregnancy test is negative, right?
Right.
You will see that when you encounter the questions. Any questions whenever you encounter of any, the secondary amenorrhea, you will see that in the U world, it has always mentioned that the patient is having a negative pregnancy test, because the most common cause of anovulation is the pregnancy. The other one is the PCOS, obesity, which is again a cause of PCOS. Any suppression of the HPO axis can cause it. Premature ovarian failure can cause it. Hyperprolactinemia can cause it, which is due to a pituitary cancer. Thyroid disorders, whether a hyperthyroidism or even a hypothyroidism can cause it. Eating disorders can cause it. I told you in the eating disorders, you're not having any protein, no energy, nothing. Okay, a proper failure of this thing happens. Competitive athletes, because if you are a patient who is doing too much exercise, that can again suppress the HPO axis, causing a loss of GnRH, loss of LHFSH. And that again, what happens in the eating disorders also, because the patients with the anorexia or the bulimia nervosa, they do too much exercises, right?
Right.
And doing too much exercise can suppress the HPO axis, causing the anovulation. Cushing syndrome can cause it. Adrenal insufficiency can cause it. Chromosomal abnormalities like the Turner syndrome can also cause it. So all of these are the causes of anovulation where you have the primary or secondary amenorrhea. Okay.
Yeah.
In Turner syndrome, you have primary or you have secondary amenorrhea?
Primary.
Primary type. So primary one in the Turner syndrome, while all other causes, I think you'll be having a secondary amenorrhea in all of them. Okay. In all of these causes, secondary amenorrhea, in Turner syndrome, primary amenorrhea. Okay.
Yeah.
And the thing that I'm discussing about this eating disorders and the competitive athletes, you call it a functional hypothalamic amenorrhea. Okay, that happens because of exercise-induced amenorrhea. Okay, it happens because of doing too much of the exercise that causes a caloric restrictions, increasing the energy this expenditure that suppresses the GnRH secretion. Okay, it will suppress the pulsatile GnRH secretion that causing the loss of LH, FSH, and estrogen. Okay, when you do too much of the exercise, you will be losing the fat. And I told you, the fat releases the leptin. Remember in the GIT?
Yes.
So because of this low leptin, high level of cortisol because of the stress, of course, because of the exercise, because of low leptin, high cortisol, patient is having a suppression of the HPO axis. Okay, this is be seen in the eating disorders. Okay, seen in the female athletes. All the females which are doing the caloric restrictions, okay, they can have the functional hypothalamic amenorrhea because of loss of LHFSH estrogen. Patient will be having a low mineral bone density. Okay, as a result, they will be at an increased risk of the osteoporosis. Okay, menstrual dysfunction will occur. Patient will get a secondary amenorrhea, right?
Right.
So that's about the functional hypothalamic amenorrhea. So let's take a short break again, and then we'll discuss the PCOS. Okay.
Okay.
Because it is kind of a big topic. So we'll discuss that after a short break.
Okay.
Okay, the PCOS, polycystic ovarian syndrome, as the name suggests, in this syndrome, you will be having a polycysts or the multiple cysts in the ovary. Okay, so one thing is for sure, you're having a multiple cyst. If you perform the ultrasound of the patient, you will find multiple cysts in the ovary. You will call it a polycystic ovarian syndrome. Along with these cysts, you're also having a high level of estrogen and high level of luteinizing hormone. And that are the three things which are contributing in this disease. Because of these three things only, you're having all these symptoms in this disorder, okay? Multiple cysts, high level of estrogen, and high level of luteinizing hormone. Okay?
Yeah.
What happens is the pathology is still unknown. Okay, it has no specific cause. You cannot say that this cause is specific for the PCOS. It is again a idiopathic condition. Somehow you start having the high level of estrogen in the patient. Now, because of the high level of estrogens, you cannot have the ovulation, because for the ovulation you need a estrogen surge, right?
Right.
Right. And because of that, you cannot have the estrogen surge. You cannot have the luteinizing hormone surge or a FSH surge also, right?
Why
you go
were we
back to the-
getting low estrogen in the first place?
See, I told you there is no specific cause for it. It is still idiopathic. Somehow, genetically or maybe from any other cause, still don't know. But what happens is suddenly you're starting having the high estrogen levels. Okay. No specific cause for that. Because of this high level of estrogen, you cannot have the estrogen surge because of that, right?
Right.
Because the levels are already high. You need a surge for the ovulation, right?
Right.
Because of that, you know, you cannot have also the surge in the LH and FSH also, because it's the estrogen that causes a surge in the LH and FSH, right?
Right.
If you're not having the surge in the LH and FSH, you cannot have the ovulation, right?
Yeah.
So because you're not having any rupture of the Graafian follicle, that Graafian follicle will become the cyst. You will call it a follicular cyst. That exactly what you see in the polycystic ovarian syndrome. Because of the unruptured Graafian follicle, that follicle will become a cyst. And further, because that follicle has a layer which is the membrana granulosa cells, right? That will secrete a large amount of estrogen again. And that forms a vicious cycle. Estrogen making the cysts, these cysts are releasing more estrogen, that estrogen again forming the cysts, right?
Right.
Now, because you're not having any ovulation, you will become infertile, right?
Yes.
So the most important thing the patient will have is the history of infertility, because they do not have any ovulation. They also have a history of amenorrhea because of chronically high level of estrogens. You won't have a cyclic changes, so cycles will be stopped. Patient will be having a secondary amenorrhea also, right?
Right.
Now, this increase in the estrogen, it will give a negative feedback to the FSH. So you will be having a low level of this FSH, okay? But you will be having a high level of LH in this case, okay? Still no cause associated with that. It's still idiopathic cause. No one knows how, why this is happening. It's just you're having a very high level of LH and a low level of FSH. Although the level of LH and FSH both are high, but if you take the ratio of the LH and FSH, you will find a very extremely high level of LH as compared to the FSH, okay?
Yes.
Now, because the cells are, because these follicles are there, the thicker internal cells will release the androgens that will cause a very high level of testosterone. LH is stimulating the thicker internal cells, release the androgens. Okay. Again, new follicles will form. Again, more LH will form some more androgen. So a same again a cycle is forming, right?
Right.
So these two cycles will be forming a high level of estrogen, high level of androgens, and again these androgens will be converting into the estrogen, right?
Right.
So a high LH, normal or slightly increased FSH, but again a ratio is very much high level of androgens, high level of estrogens. All of these hormonal irregularities making the cysts in the ovaries. And these are the follicular cysts, and these cysts will be releasing all the androgens and all the estrogen from them, making a vicious cycle again, right?
Right.
So that was the pathology behind the PCOS. Cause is still unknown. No one knows why it is happening. It just there is a hormonal imbalance that is initiating this condition, and that hormonal imbalance is increasing the LH and estrogen in the patient's body. That is again making all these cycles. Okay. Now, what are the symptoms you will get? Let's talk about that. So you will categorize the symptoms into four major headings. Let me show that. Give me a second. See, first you will be having a menstrual irregularities. Okay. Now, because of the chronically high level of estrogen and LH, you won't be having any surge. Because of high level of estrogen, not the cyclic changes, you won't be having any cycle. Patient will get a primary or a secondary. Mostly it is secondary, least, and in least causes, it could be a primary also. Okay. Patient could get the oligomenorrhea also. Menorrhagia can happen because once you get the cycles, you will get a very severe or abnormal intrauterine bleeding could be there. Menorrhagia will have happened, right? Patient will having the infertility or difficulties in the conception or the conceiving. Okay.
Yes.
Second thing, please note, other risk factors. Let's talk about first. So these are menstrual irregularities you will get. Now let's talk about other the risk factors you will see in these patients. Open the first aid again. Yeah. So these things are specifically seen, most commonly seen in the patients with the obesity. I told you in the obese people, they have, all these, just give me a second. I'm forgetting the name actually. Adipocytes, right? Sorry about that. Sorry. In obese people, you have large amount of adipocytes, right?
Yeah.
And these adipocytes contain the aromatase, right? Yes. Yeah. So because of this obesity, you will have a very increase in the peripheral conversion of the estrogen from the androgens, right? That again causes a high level of estrogen. Okay. And that again, high level of estrogen will be preventing the ovulation, will be causing the cyst formation, will be causing a high level of LH, FSH, again making the cycles, right?
Right.
Okay. So it is most strongly associated with the obesity because the obesity will cause the increased peripheral conversion of the estrogen from the androgens, right? By the aromatase. Because of the obesity, patient will also be having an insulin resistance, right? Because I told you, whenever you have a high level of triglycerides, these triglycerides will cause the insulin resistance, right?
Right.
So the patients will also be having the insulin resistance. So hyperinsulinemia will occur, or you can say a type 2 diabetes mellitus will happen in these patients, right?
Yes.
Because of this hyperinsulinemia, patient can also have a hypodermal hyperplasia and hyperpigmentation that can lead to the acanthosis nigricans. Remember dermatology, we have discussed about the acanthosis nigricans, where you have the hyperpigmentation of the skin folds, leathery appearance will be seen, right?
Right.
Androgen productions will be increased. You will get the hirsutism and the virilization, right? Because of the chronically high level of LH, you will get the anovulations that will cause the infertility again, right?
Right.
Because of this chronically high level of estrogens, this will cause a proliferation in the endometrium, right?
Yeah.
Endometrial hyperplasia will occur, and that hyperplasia, I told you, whenever you have a hyperplasia, you will always can have a cancer. Yes. Because of that, right? So this will increase the risk of having an endometrial carcinoma, right?
Right.
So the exact pathology is still unknown, but this condition starts with the obesity. In the obese people, they started having the high estrogen levels and high LH levels. No one is sure why these LH levels are there, but they're just having a high LH levels and high estrogen level. The high LH level and the high estrogen level will prevent the ovulation, will be forming the cysts. These cysts will releasing the androgens and releasing the estrogen, forming this vicious cycle that will repeat again and again. With each cycle, you will have the addition of one more cyst. Okay, with year, with months, patient will be having the PCOS. Okay.
Yes.
Now let's discuss the symptoms again. So first you'll be having a menstrual irregularities that we have discussed because of high level of androgens, high level of estrogens, chronically high level of LH, and ovulations will happen. Oligomenorrhea will happen. Amenorrhea will happen. Menorrhagia can happen. Infertility can happen. Because of the insulin resistance due to the obesity, patient can have a metabolic syndrome. And I told you the features of the metabolic syndrome: central obesity, high these LDL levels, low HDL levels, right? Hypertension can happen. And because of the obesity, patient can have a risk of increase in sleep apnea, right?
Yeah.
Because of the obesity, because of very high fat in the liver, patient can have a non-alcoholic fatty liver disease also,
Right.
right? And what are the features of this non-alcoholic fatty liver disease? What you will see?
Fatty degeneration of the liver tissue.
Yeah, hepatosteatosis, right?
Yes.
You will have a fat accumulation in the liver. You will see all these clear cells within the liver, the hepatocytes, right? So that is a non-alcoholic fatty liver disease. You will get the hepatomegaly because of that. Now, because of increased level of these hormones, insulins, and androgens, patient can have skin conditions also that are the hirsutism because of high level of androgens. Because of high level of androgens, patient can also have an androgenic alopecia. Because of high level of androgens, they will release. Actually, they will cause the activation of the sebaceous glands. Remember,
Yeah.
sebaceous production will increase. Patient will get the acne vulgaris because of that. These patients always they have a history of acne. Okay, I have a friend, many friends who have these conditions. They all have the acne. I think 2 or 3 friends I have. Okay, and oily skins will be there because of increase in the oil production by the androgens again. Because of high level of estrogens, patient can have a acanthosis nigricans also. Because of this hormonal these things, the patient can also have a psychiatric conditions like the depression or maybe the anxiety. Okay.
Yes.
So whenever you encounter an obese patient who is having a acne, always think about the PCOS. That is the only 2 symptoms, or most of the times, these 2 symptoms will be the major one the CV will give you. Okay. This patient who is wearing this patient is obese and she's having a acne. These 2 things will give you. They will give you, and that's how you will know that the patient could be having a PCOS. The patient will be having a history of infertility. They will be having a history of secondary amenorrhea, and that will again make you sure that this condition is a PCOS. Okay. Again, let's go back to the first aid. Yeah. So after you encounter such patients, okay, after you know that the patient is there, that the patient is having an amenorrhea history, patient is obese, having an acne, how would you confirm your diagnosis? You need to perform the tests, right? Right?
Yeah.
So what test you will do? You will first check the ultrasound of the patient. On the ultrasound, you will see the multiple cysts in the patient's body, right?
Right.
In the labs, you will check the LH and the FSH levels. What you will find? A high ratio of the LH to FSH. High level of androgens will be seen in the laboratory. High level of estrogens will be seen in the laboratory, right? In the blood levels, you will see that, right?
Yes.
On the metabolic examination, what you will find, patient will be having a very high BMI, hypertension, okay? Diabetes will be there in the patient, hyperlipidemia will be there in the patient, right? Now, after seeing all these conditions, you can check whether you can see that the patient could be having a PCOS. Of course, he's having multiple cysts. So now, other thing you can do is perform the biopsy of the patient or check the this ovaries of the patient, right? The gross examination could be done, right?
Right.
So after removing the ovaries, you can check the gross examination. On the gross examination, you will see the multiple cysts are present in the ovary, and these cysts are kind of brown in the color maybe. Okay. On the microscopic examination, you will see the granulosa cells. You will see the theca cells in the cysts. Okay, hyperplasia, fibrosis, hypertrophy. All these things will be seen on the microscopic examination. That's how you know that the patient is having a PCOS. Okay.
Yeah.
So see a clinical picture of the patient completely. You will encounter a patient having a history of obesity, having a history of acne, amenorrhea, infertility. You will check the blood level of the patient of all these hormones, LH, FSH, androgens, and the estrogens. You will check the ultrasound of the patient, all the ultrasound. I hope you can guys see that. These are the cysts you will see, right?
Yes.
And this is a transvaginal ultrasound you will see. Okay, if you perform the ultrasound, you will see the bilateral cystic ovaries on the both side. With each cycle, you have the addition of cysts, multiple cysts that will cause the PCOS again. Amenorrhea, menorrhagia, hirsutism, acne, okay, and all these skin conditions, psychiatric conditions, infertility conditions, okay, metabolic syndromes will be there in the patient. Okay, so any doubts so far about the PCOS?
No, thank you.
Now, what treatment you will give? Of course, all this symptomatic treatment will be given to the patient. For the acne, patient should be taking the OCPs, because whenever you take the OCPs, it will increase the estrogen levels further. That will decrease the all these androgen levels. Okay.
Okay.
So this OCPs will be very helpful for both the acne as well as to treat the endometrial hyperplasia, because in the OCPs you're having the progesterone, right? That will prevent the action of estrogen. Yes. So this condition will prevent the endometrial hyperplasia and decreases the risk of endometrial cancer. It will also help the patient in the acne. Weight reduction is a very important treatment you will give to the patient, because this condition starts with the obesity. So treating the obesity is a very important treatment you will give. Okay, for the ovulation induction, please note the important tablet you will give the patient is a clomiphene citrate or the clomiphene. Okay, this is again a receptor modulator of the estrogen. It will it will block the receptors for the estrogen in the pituitary, and as a result, you will have an ovulation because of loss of negative feedbacks. We'll discuss that later, how this clomiphene citrate work. Okay, so this clomiphene citrate will cause the ovulation in the patient. Whenever you encounter a patient having a history of this amenorrhea or no ovulation, you will always give them the clomiphene. Okay, doesn't matter if they're having a PCOS or any other cause. Okay, if they're having history of amenorrhea or no ovulation, you will always give them the clomiphene. Okay, infertility case, whenever I encounter infertility case, we'll first give them the clomiphene. This will cause the ovulation in the patient, and this will help the patient in the pregnancy also. Okay. Now, if this clomiphene citrate does not work, the other treatment could be given. Okay, and that includes giving the patient the alpha subunit of the HCG. And I told you, because it is structurally similar to the LH, it will cause a surge in the LH levels, right?
Right.
So that can again lead to the ovulation in the patient. So what happens is, up to the 12 days, you will give the patient FSH therapies. Okay, analog of the FSH will be given. After the 12th day, you will give the patient high dose of alpha subunit of the HCG that will cause a surge in the LH levels, and that will again cause the ovulation. That will promote the fertilization in the patient. So if the step one asks you how to promote the fertilization, one is the clomiphene. If the clomiphene doesn't help, you can give the patient this HCG therapies as well as the FSH therapy. Okay. To treat the hirsutism, you can give the patient spironolactone, which is anti-androgen, finasteride, flutamide. Okay, and OCPs can also be given for the hirsutism. Okay.
Yes.
And please note, by giving the patient OCPs, you will be increasing the steroid hormone binding globulin. That will increases the total level of androgens, but decreases the free level of androgens, right? Because they bind to the androgens. Okay.
Yeah.
So they bind to the androgens and decreases the level of free androgens, causing a symptomatic relief from the high androgen levels. So this will prevent the acne, this will prevent the hirsutism in the patient, this will prevent the endometrial hyperplasia. That's why the OCP therapies is very important. I think that would be all about the PCOS. Any doubt, please ask.
No, thank you.
Okay. Now you have the primary dysmenorrhea, and this is again a painful menses. Remember a mid-ovulatory pain condition?
A mid?
Yeah?
Medical skin and something.
Yeah.
Yeah.
Michelin Morris, right? You'll be having a very painful condition, and you have a pain with the ovulation in the mid-cycles. Every month you will have a pain, right? So if you have a pain with the bleeding, it will be the primary dysmenorrhea. If you have pain without bleeding, it would be a mid-ovulatory cyclic pain, right?
Right.
So in these conditions, you will be having a uterine contractions, and the uterine contractions are there to decrease the blood loss. So whenever you have a menses, uterine contractions, mild uterine contractions always happen. And that's why all these menses are slightly painful. But if too much contractions happen, this will create a very painful condition to the patient. Okay. And that again causes the primary dysmenorrhea. Okay. And again, that will be mediated by the prostaglandins, because the prostaglandins will be causing the uterine contractions, right? See, it is not by the, these contractions are not by the oxytocin. Okay. because the oxytocin can only work in the pregnancy in the third trimester, right?
Right.
So these contractions are not because of the oxytocin, but because of the prostaglandins. So the treatment of this condition is again the NSAIDs. Okay. Yeah. So that's about the primary dysmenorrhea. Any doubt?
I had one question.
Yeah.
When we're talking about the functional hypothalamic amenorrhea,
Yes.
the decreased leptin has a direct effect in decreasing my GnRH.
Sorry, repeat it again, please.
In
Decreased
the
leptin has?
Does the leptin, the fact that you don't have leptin tells
Yes.
your body to just not release GnRH, or is it like
GnRH is releasing, but not in the pulsatile manner. See, you require the pulsatile release of the GnRH, right?
Mhm.
But when the leptin levels are decreased, it will cause, the dysfunction with other hormones also. And ultimately, this will be causing the inhibition of the pulsatile GnRH secretions. A continuous GnRH will be released that will suppress the HPO axis.
Okay.
Okay.
Thank you.
That
Yeah.
exactly happens. Both the increase, the decrease in the leptin as well as the increase in the cortisol, they both will cause this thing. Okay.
Yes. Thank
That was about it. Now comes the cyst. Okay, we have discussed this cyst already. You have two types of cyst. One is the follicular cyst that's seen in the PCOS, and second is the thicker lutein cyst that's seen in the hydriform moles. Yeah, hydriform moles and the choriocarcinoma. Right, these two conditions you will see the thicker lutein cyst. In the PCOS, you will having the follicular cyst. That happens because of an unruptured Graafian follicle. And again, when the Graafian follicle is there, you will be having a high level of LH, high level of androgens, as well as high level of estrogens, right?
Right.
So hyperestrogenism can occur, and again, this hyperestrogenism can lead to this condition. Endometrial hyperplasia can also occur. Okay, and yeah, that's all about these two cysts. And doubt, please ask. Thicker lutein cyst can always happen whenever you have a high HCG levels, right?
Yeah.
Any doubt on this cysts?
No, thank you.
It's just to see with them other conditions, right? Like the PCOS, like the this choriocarcinoma, right? This molar pregnancy, you can have these kind of cysts, either the thicker lutein cyst in the molar pregnancy in the choriocarcinoma or the follicular cyst in the PCOS. Now you have the ovarian neoplasms, and these are the first, second, or third most common cancer.
Third.
Yeah, third most common cancer, and mortality wise, first highest mortality, right? So these tumors, of course, they will be originating from the ovaria. Okay, from the ovaries, they will be originating. So if you perform the ultrasound on any of these patients having any of these cancers, what you will see is the intra-ovarian adnexial mass, right?
Right.
So step one in the CV always mention that the patient is having an intra-ovarian this adnexial mount, this mass on the ultrasound that you will see on any of these patients. Okay. Most commonly, all these neoplasms will occur in a woman of more than 55 years of age. That means a post-menopausal woman. Okay. The patient will be having a pain, abdominal distension. Because of the mass, patient can also have a bowel obstruction. Constipation could be there. Pleural effusions can also happen because of the metastasis or maybe because of a secretion from these cancers. Okay. So because of these things, patient can be having a respiratory distress also, right?
Right.
Abdominal distension can also happen because of the increased secretions or having a peritoneal effusions could be. Okay, so that can again lead to the abdominal distension. A patient having abdominal distension, having a mass in the unilateral side of the body in the pelvis, in the lower abdomen. Okay, that you can see on the palpation of the patient also. You perform the examination, you palpate a mass in the lower abdomen or in the pelvis. You can think about the ovarian cancer. Obstruction can be there, pleural effusions can be there. Risk will be increased with the advanced age because I told you this case will be seen in the 55 years old female. So with the increase in the age, the risk will always increases. Infertility will increase the risk of the neoplasms. Endometriosis will increase the risk of the neoplasm. We will discuss what this condition is later. PCOS can cause these conditions. Genetic predisposition, if the patient is having a mutations in the BRCA1 and the BRCA2 genes, the patient could be having the ovarian neoplasm, and this is a familial condition, right? Multiple family members will be having all these ovarian and endometrial neoplasms if you got a BRCA1, BRCA2 mutations, right?
Right.
So a spontaneous case, infertility, advanced stage, endometriosis, PCOS. Okay, a familial case where the patient's multiple family members having these cancers, BRCA1 or BRCA2 mutations. Okay, Lynch syndrome, if you guys remember, the classical triad in the Lynch syndrome.
Colon, endometrial, and ovarian.
Yeah, the colon, endometrial, and the ovarian cancer you will see. And all of these things, the patient will be having a strong family history. Okay. Now, risk of the cancers will be decreased with the previous pregnancy because infertility increasing the risk. Previous pregnancy will be decreasing the risk. Breastfeeding will be decreasing the risk. Taking the OCPs are very helpful in preventing the risk of these cancers. Tubal ligations can cause it. Okay, that means oophorectomy can cause it. Can play a very protective role in these cancers. Okay, so oophorectomy will be done. Okay, so all these things will decrease the risk and all of these things will increase the risk. Step 1 will ask you, they will give you 2, 3 options, 4 options, and they will ask you out of all these options, which of the following will decrease the risk of these cancers, or after giving 3, 4 options, patient the question will ask you what would be the most important factor in this patient to got this ovarian cancer. So looking at the family history, you can see that if it is a mutation. Looking at the condition of the patient, if she is having a PCOS, that means the PCOS is there. If she's having a symptoms of the PCOS, okay, if she's having a history of infertility, that means it could be due to infertility. If the patient is not having any of this history, that means advancing age is very important role, right? Right. Now, looking at the site of the tumor, you have multiple tissues in the ovary, right? You have the epithelial layer of the ovary, that is a cuboidal epithelium, remember?
Yeah.
So the tumors can be arise from this cuboidal epithelium, and you call it epithelial tumors. And the very important characteristic features of these epithelial tumors is that they release the CA125. And whenever you have a high level of CA125, it will make you think about the epithelial tumors. Is that okay? Yes. Okay, so CA125 is a cancer marker for the epithelial tumors. Okay, now going inside the ovary, you will find the stroma in the ovary, right? The stromal tissue in the ovary, that is a kind of a liquid tissue maybe, right?
Yeah.
And that stroma, you will have a tumor from that stroma, you will call it a sex cord stromal tumor. Okay, it will come into the headings of sex cord stromal tumors. Now you have the graphene follicle, for example. This follicle contains the membrane granulosa cells and the theca cells on the outside, right?
Right.
And after theca cells, this follicle contains an egg ovum, right?
Yeah.
So if the tumor arises from this ovum, from this egg, you will call it a germ cell tumor. Many types of germ cell tumors are present, like dysmelanoma, cystic teratoma, or immature dystratoma, or maybe a yolk sac tumor, right? Tumors can also arise from the granulosa cells or from the theca cells, right? If the tumor arises from the theca cells, you call it a thecoma. If the tumor arises from the granulosa cells, you will call it a granulosa cell tumor, right?
Right.
And again, these tumors will come into the heading of sex cord stromal tumors. Okay. Yeah. So let's discuss all these tumors one by one. Now for the epithelium, okay, you can be having 2 types of cancer. One is the serous cancer and second is the mucinous cancer. If this tumor is releasing the serous fluid, you will call it a serous tumor. If the cancer or the tumor is releasing the mucinous fluid, you will call it a mucinous tumor. Okay, it could be of 2 types again, either the benign condition or maybe a cancerous condition. If it is benign, you will call it a cyst adenoma. If the cancerous or a metastatic condition is there, you will call it a cyst adenocarcinoma. Okay.
Right.
So based on all these things, you can either have the serous cyst adenoma or serous cyst adenocarcinoma, or mucinous cyst adenoma or the mucinous cyst adenocarcinoma. Okay, again, benign, malignant, benign, malignant. The most common type is a serous cyst adenoma. Okay, and in that condition, they will ask you what kind of a histology you will see, what kind of a cell you will see in the patient. Okay, so please note, if you take the biopsy of the patient, okay, then all these cells which are releasing this serous fluid, they will mimic the fallopian tube-like epithelium. They will have the fallopian tube-like epithelium. Okay.
Could you repeat this
Okay,
thing
so
once?
if you perform the biopsy of the patient, on the biopsy, because it is a tumor of the epithelium, right?
Yeah.
What you will find on the biopsy is a fallopian tube-like epithelium, which is releasing the serous fluid. Because from the fallopian tube, the serous fluids will be released, right?
Because
Right.
it's columnar, right?
Yeah.
The
Because
fallopian tube is columnar.
yeah, of course.
Columnar,
The
which
fallopian
is
tube is
why
yeah.
which is why it's
Fallopian tube is
serous.
columnar. Yes.
Okay. Cool.
Okay.
Thanks.
So, and from the fallopian tube, you have the serous secretions. You also need to know that. Okay. The columnar cells in the fallopian tubes, they are releasing the serous fluid. This is a normal thing. Okay. And again, these cells are also releasing the serous fluid. So these the epithelium of these tumors is mimicking, or will be like the fallopian tube epithelium. Okay. You're not getting that?
No, I got it.
Okay, so see that condition. Okay, whenever you have a serous secretions from and because the serous secretions are from the fallopian tube, so these cancers will have a fallopian tube like epithelium. Now the tumors which are releasing the mucinous fluid, so please note, the mucinous fluid will be released by the will be released by the cervix. Okay, under the influence of the progesterone, the cervix releases the mucinous fluid that will block the entry of sperms, if you guys remember that.
Yes.
In the progesterone part, we have discussed that the progesterone will always prevent the entry of sperms by releasing the thick secretions, right?
Yeah.
Is this related
And
to
that
the,
thick, yeah,
this is related to the mucus plug?
yeah, mucus plug, of course. Okay, so mucus is basically a very thick secretion, right? And that is released by the cervix. So the tumors which are the mucinous cyst adenoma and mucinous cyst adenocarcinoma, they will have a mucus secreting epithelium that is normally found in the cervix. So their tumor epithelium will resemble like the cervical epithelium. Is that okay?
Yes.
Okay, so the serous epithelium found in the fallopian tube and the mucinous epithelium found in the cervix. Both are the columnar, of course, but it's just the fluid that they release. Serous is basically a very thin fluid, watery kind of fluid. Mucin fluid is very thick in nature. Okay, and yeah, that's all about these two things. Okay, so in the serous cystadenoma, which is the most common tumor, cyst adenocarcinoma, it is the most common malignant tumor. Okay, and you will find the samoma bodies in that condition. Okay, papillary cells will be seen and samoma bodies. I hope you guys remember about the samoma bodies.
Circular structures, circular
And-
column, necrosis
And
in the
how
middle.
these bodies are made.
Necrosis of the tissue
Necrosis of cells.
and calcification.
Yeah, necrosis and calcification in a concentric layers, right?
Yeah.
So that will be the samoma bodies will be seen in the cyst adenocarcinoma. Okay, in the mucinous one, you will be having a multinucleated cells. The multiloculated large cells will be there. Okay, and you will be having cells which are lined by the mucinous secreting epithelium, and that's why the mucinous. Okay, mucinous cyst adenocarcinoma, again a malignant tumor. Okay, you can be having a pseudomyxoma peritonitis because of that, because of the secretion of the mucinous fluid. It will cause the accumulation of all this mucus material within the peritoneum, and that again will be causing the abdominal girth increase, right? Remember the abdominal distension?
Yeah.
That again will be happening because you're having an accumulation of all this mucinous material within the peritoneum. Okay, so you will have the pseudomyxoma peritonitis because of that. Okay,
Yes.
so that's about these 4 tumors. Any doubt, please ask.
No, thank you.
So CA125 is common for all of these, okay? Now you have the Brenner tumor. And the most important thing you must remember about this tumor is when you perform the histology, when you perform the biopsy, you will find the bladder-like epithelium in this tumor. Okay, the uroepithelium-like epithelium is present in the Brenner tumor. Okay, it will be on the gross examination, it will be a solid, pale yellow tumor from the ovary. Okay, so you have the ovary. From the ovary, you will be having a pale yellow tumor, okay, which is a tan in the color, solid pale yellow tan color tumor, okay, which is encapsulated. You perform the biopsy. On the biopsy, you will find the coffee bean nuclei. And does anyone remember what this term means?
And there's a line down the middle.
Yeah, in the nucleus, right? So if this is my cell, this is the nucleus of the cell, for example, there we have a large nucleus because of increased NC ratio, and the nucleus will be cleaved like that, right?
Yeah.
So that kind of a cells you will see on the Brenner's tumor, the coffee bean nuclear-like cells on the H&E stain. Now, please note, these coffee bean-like cells can also be seen in one other this tumor also. And does anyone remember the name of the tumor?
In a brain tumor.
Not in the brain, in the ovarian cancers also you will find these coffee bean nuclear-like cells. The granulosa cells tumor. In the next page we will discuss, okay, don't worry. The granulosa cell tumor, they also have this coffee bean nucleus, so do not get confused. Okay, look for the history of the patient, symptoms of the patient, because whenever the patient is having a granulosa cell tumor, they will be also having a high level of estrogen, right?
Right.
So symptoms of high estrogen, high progesterone will be present in the granulosa cell tumor. Along with these symptoms, if the patient is having a coffee bean nuclei, you will think about the granulosa cell tumor. If the patient condition is asymptomatic, just a mass is present, which is tan yellow colored, and now you having this coffee bean nucleus and a bladder-like epithelium, you will think about the Brenner's tumor, okay?
Yeah.
So
That's
does
about
the
the,
Brenner
yeah.
have is it the Brenners that you said had the high estrogen, or were you just talking about the granulosa has the high overall
Granulosa
estrogen?
cell tumor will have a high estrogen. Well, of course it is, this makes sense because it is function of these cells, right?
Yeah.
These cells will secrete the
Also,
estrogen.
no, I was also asking because this is a yellow color. The Brenner's tumor is yellow, so I thought it might also have some sort of.
No. That was not the condition here. It is a silent condition, okay?
Okay,
It
thank you
won't
so
release
much.
anything. It's just a solid pale yellow tumor with the capsule, okay, and having a coffee bean nuclei. So that was about all these epithelial tumors. In all these tumors, we'll be having a CA125 common, okay?
Yes.
Now, any doubt, please ask.
No, thank you.
Does the pseudomyxoma peritonei, is that also seen in the appendix as well? Or is that something at all?
Appendix? Sorry, I don't understand.
I will Google and then I'll put in the chat. Thank you.
Okay. Sure. Okay, now you have the germ cells tumor, and the germ cells tumor will arise from the ovum, right?
Right.
And it contains all the fetal tissue, okay?
Yes.
So the fetus has a yolk sac, okay? Fetus has a immature cell layers, okay? The epiblast, hypoblast, I hope you guys remember.
Yeah.
Right? Fetus has, the placenta also, right?
Right.
So the choriocarcinoma is a type of germ cell tumor, okay? Which is not mentioned here. It has because mentioned earlier, so the FA doesn't mention it here. But the choriocarcinoma is a type of germ cell tumor. The most common type is the dysgerminoma. Okay, it is most commonly found in the adults. Okay, it is a male equivalent of the male seminoma equivalent. Okay, that is seminoma is the male seminoma equivalent. Both in case of seminoma, both in case of dysgerminoma, you will find the fried egg cells. And I hope you guys remember one brain tumor where you can have the fried egg cells, which can,
Oligodendroglioma, dendrocytoma, sorry.
okay, you can have the fried egg cells in the oligodendrocyte, this oligodendroma also. Very good. And I hope you also remember one tumor which is again a counterpart of the seminoma in the brain.
Pineal?
What tumor?
The pineal also.
Yeah, the pineal gland tumor. Yes, that tumor will again release the HCG, right? It will release the LDH. Okay, so pineal gland tumor is again a counterpart of the seminomas and the dysseminomas. Okay, and that's why you call it a germ cell tumor of brain, right?
Mhm.
The pinealoma is a germ cell tumor of the brain because it again has all these Friedrich cells. It has features like the seminoma and features like the dysseminoma. It will has and that tumor can also release the HCG also. Okay,
Yes.
so that was about the dysseminoma. You will get the ovarian mass. Okay, on the ultrasound you will see ovarian mass, unilateral ovarian mass. You will perform the biopsy of the patient, and on this mass you will find that mass is a very solid structure, not a cystic appearance, because if it is cystic, that means it could be a PCOS, it could be anything, but the mass here is a solid mass. On the examination, on the biopsy of that solid mass, you will see the fried egg cells, and that's how you know that the patient is having a dysseminoma. As you can see here, this is a complete cell. Okay, and you can see this is a nucleus of the cell, right? A clear cytoplasm is present. This is one cell, a clear cytoplasm, again a cell and a clear cytoplasm, right? Okay, so this is a fried egg cell that is having a clear cytoplasm, so you cannot stain the cytoplasm, but you can stain the nucleus. So that will give you this appearance. Okay.
Yeah.
Then you have the mature cystic teratoma, and this is the most common benign tumor. Okay, it is also known as a dermoid cyst. Okay, and basically what happens is it basically arises from the germ layers of the fetal tissue. Okay, and what are the three germ layers?
Ectoderm, endoderm, mesoderm.
Ectoderm, mesoderm, and endoderm. So this tumor is arise from the ectoderm, mesoderm, and endoderm. So it contains all the elements which are arising from these three layers. That means the teeth, hair, sebum. As you can see here, this is the hair in the ovary, right? And this is the teeth in the ovary, right?
Yeah.
So these kind of structures will be present in the ovary. On the gross examination, you will see the hairs are coming out of the ovary, teeth are coming out of the ovary. Okay, sebum is present. As you can see, this is all the sebum rich area, right? This yellowish part you see. This is all the sebum. So this kind of a tumor it is. It can form any structure. It can form the bones. It can form the skin. It can form the adipocytes. It can form the hair. Okay, because it contains all the germ cell layers, right?
Right.
Now, this tumor, whenever it enlarges, it becomes a very painful condition whenever the ovarian torsion occurs. I told you for the ovarian torsion, you requires any mass in the ovary, right?
Yeah.
That will make the ovary unstable. So teratoma is the most common tumor that can cause the ovarian torsion, or because of the enlargement of this tumor, patient can again have a mass symptoms, abdominal pain could be present. If the thyroid tissue is present in the ovary, you will call it as struma ovarii. Okay, and as you can see, this is the thyroid tissue. Okay, these are all the thyroid follicles, and this is all the material in the thyroid, right?
Right.
So this kind of a thyroid material could also be present, and you call it a struma ovarii. So in this condition, patient can also have a hyperthyroidism. So whenever you encounter a patient having a ovarian mass, a solid ovarian, not a cystic one, please note, always a solid, right? So a solid ovarian mass having a hyperthyroidism, we will think about the mature cystic teratoma. Is that okay?
Yes.
The male counterpart of this cystic teratoma, it is always malignant, while the female counterpart is the benign. Okay, we should know that also. We will repeat that again. The male counterpart of this teratoma, the male teratoma is always malignant condition, but the female teratoma is the benign condition. Okay.
Yes.
Third tumor will be the immature teratoma. You cannot have any differentiation. Like in that case, you are seeing the three germ layers, the teeth, hair, sebum, right? You can be differentiate. Okay. But in case of the immature teratoma, you cannot differentiate between the structures. So immature embryonic-like neural tissue will be present. And this condition always seen in the adolescent females. That means before the 20 years of age. Fetal tissue will be present, neurocrine will be present, but not differentiated, not into these structures. You cannot have hairs, teeth, sebum, or bones, or anything because no differentiation is present. It's just the embryonic tissue is present and seen in the patients before the 20 years of age. Okay.
Yes.
This tumor is very much malignant and very much aggressive also. Other tumor which arises from the yolk sac, and that is the endodermal sinus tumor or a yolk sac tumor. It's seen in the children. Okay, small children. It is seen. Okay, so a small children who is having a very solid mass in the ovary, you perform the biopsy of that mass. On the biopsy, you will find the scleroduval bodies, and these are the bodies which resemble the glomerulus. If you look at the glomerulus, let me draw that. On the glomerulus, what we'll see, you will have this kind of a outer layer of the Bowman's capsule. Inside it, you're having this blood vessels, right? It is all the clump of the blood vessels, right?
Yeah.
And this is a normal glomerulus. As you can see in this condition, there is in the center, you have the blood vessels. Surrounding the blood vessels, you have the columnar cell layer, right?
Yeah.
So this kind of a thing will be seen. So in the central portion on the biopsy of the patient, what you will find are the multiple areas where in the center, you will have, the vascular area, a core, which is made up of the blood vessels. As you can see, these are the RBCs. Let me zoom. So, yeah. So on the center, you can see all these RBCs are present, and this is a central vascular core. And that central vascular core is surrounded by the columnar cells or the cuboidal cells that you will find on the biopsy of the patient. Okay.
Yeah.
So that's about the yolk sac tumor or the endodermal sinus tumor, and that tumor releases the alpha fetoprotein from it. Okay, so you can have a rise in the alpha fetoprotein levels because of 2-3 conditions, and I hope you guys remember from the neurology what conditions can have a high level of alpha fetoprotein.
Neural tube defects.
Neural tube defects. Okay, and then
Down syndrome.
Down syndrome, high or low level of alpha fetoprotein.
I'm not
It's
sure.
low.
I think low level of, yeah,
Low
you will have a low level of, yeah, not the high level, low level. But other tumors can have a high level of alpha fetoproteins. Liver,
Liver.
right? Liver you can have, yes. And again, then in case of your yolk sac tumor, you can have a high level of alpha fetoprotein. So that's why this, this tumor marker is not a diagnostic, right? You cannot use it for the diagnosis, but you can use it for the recurrence, to monitor the recurrence of the tumor, right?
Right.
Because once you know that the rise in the alpha fetoprotein levels in this patient is because of this tumor particularly, so whenever in the next time you have the rise of this alpha fetoprotein levels in this in this patient, you will immediately know that this rise is because of that particular tumor only, right? Not because of any other cause. So you can use this marker for the recurrence only, not for the initial diagnosis. Okay.
Yes.
And please note, on the gross examination, that means on the ultrasound, what you will see is a hemorrhagic mass. So a child who is having a unilateral mass in the ovary, on the palpation, you will see the mass in the patient, lower abdominal or the pelvis. You perform the ultrasound of the patient. On the ultrasound, you will find a hemorrhagic mass. You perform the biopsy of the patient. On the biopsy, you will find these kind of scleroduval bodies, okay, that resemble the glomerulus. That means that your bodies will be having a central vascular core surrounding by the columnar or the cuboidal cells. You will immediately know that the patient is having a yolk sac tumor. You will perform the tumor marker test. You will find a high level of alpha fetoproteins also. Any doubt, please ask.
No, thank you.
Finally, you have the sex cord stromal tumors, and these tumors will arise from the sex cord or from the stroma. Okay. From the stroma, these are the stromal tumors. From the sex cord, these are the Gilnow cell tumors or maybe the thicker cell tumors, right? So the thicker cell tumors are known as a thicoma. Okay, and these tumors will produce the estrogen. Okay, and that causes the abnormal uterine bleeding in a post-menopausal female. So this condition always seen in a post-menopausal female. So whenever you encounter a patient who is post-menopausal having a vaginal bleeding abnormal, you will always think about the thicoma, right? Most of the time think about the thicoma, while other causes can also be there. but thecoma is one of them also, right? You will check the estrogen levels of the patient. You will find a very high level of estrogen in them. Okay.
Yes.
Second tumor is the granulosa cell tumor, and the granulosa cell tumor will release the estrogen again. Okay, it's seen in the women who are in the 50s. Okay, so again, these patients will be having a post-menopausal bleeding because of the endometrial hyperplasia, because of high level of estrogen. And that cancer will also increase the risk of endometrial cancer. Is that okay?
Yeah.
Why? Because you're having a high level of estrogen, which is causing the hyperplasia, and hyperplasia always increases the risk of cancer, right? So these patients, both the thecoma as well as the granulosa cell tumor, they both will be at an increased risk of developing the endometrial cancer also. Okay. If now see, most of the times this condition happens in the postmenopausal females. And whenever this happens, patient can have a postmenopausal bleeding. But when this condition happens in the adolescents, because of high level of estrogen, patient can have a sexual precocity, right? Precocious puberty can happen in the patient. And I hope you guys remember the risk factors for the precocious puberty, peripheral risk factors. I told you. The theca cell tumor, the granulosa cell tumor, remember?
Yeah.
Because it releases a large amount of estrogen that can cause a precocious puberty. Okay. On the histology, please note you will find the Karl Exner bodies, not the skeletal bodies, but the Karl Exner bodies. Okay.
Yeah.
And on the Karl Exner bodies, see, in case of the skeletal bodies, you will be having a vascular core which is surrounded by the tumor cells. Okay. But in case of Karl Exner bodies, it would be a eosinophilic core, a diffuse eosinophilic core, homogeneous type, which is surrounded by the columnar cells, or maybe you can see, all these cells, the cuboidal cells. Okay. Either a cuboidal or the columnar cells could be there. Okay. So as you can see, this is the central eosinophilic core. Okay. And all these cells are surrounding this eosinophilic core, forming a follicle-like structure, right?
Right.
So let me draw this. So this is a eosinophilic center. Okay, and this center is surrounded by the cuboidal cells or the columnar cells. Okay, and whenever you see this kind of a structure, you know that it is a follicle, right? That's how the follicles look, right?
Right.
So on the biopsy of the patient, you will see multiple follicles. And when you examine a follicle on the high power field microscope, you will find the eosinophilic center in each follicle. And that eosinophilic center is surrounded by the cuboidal cells. Okay. When you further zoom on these cells, these cuboidal cells, what you will find that these cuboidal cells are having a coffee bean nuclei. Okay.
Yes.
So that's what you see on the histology of the patient with the granulosa cell tumor. Is that okay?
Yes.
So step 1 will always give you histology, and based on the histology, you will decide what kind of a cancer it is. You can be confused between the yolk sac tumor and between the granulosa cell tumor on the histology, because in both the cells, in both the cancers, you will be having a follicles which are surrounding some kind of a structure. But please note, in case of the yolk sac tumor, which is the skeletal bodies, you will be having a surrounding, you will be having a cells which are surrounding a vascular core. But in case of my granulosa cell tumor, the cells will be surrounding a eosinophilic core. Okay.
Yeah.
Now you have the Sertoli cells tumor. Okay, and these cells, because the Sertoli cells and Leydig cells tumor, they are found in the males, right? Mostly.
Yes.
So basically, they resembles the testicular histology. You have the tubules, you have the Sertoli cells, right? You have all these things, and these tumors, they will release the androgens, and because of that, patient will be having a history of virilization, hirsutism, male pattern baldness, clitoris enlargement, acne, oily skin, right? Amenorrhea. So if you encounter a patient who is having a ovarian mass, a solid ovarian mass, along with that ovarian mass, if the patient is also having a hirsutism, virilization, you will think about the Sertoli Leydig cell tumor. Is that okay?
Yeah.
And the final one is the fibroma. Okay, as the name suggests, you will be having a fibrosis within the ovary. Okay, and in this tumor, you will be having a fibroblasts. Okay. And this tumor will, because a large amount of fibrosis is present, so this tumor will appear as a hard gray white mass because the fibrosis is white, right? Scar, for example, it is white, right?
Right.
So this tumor is kind of a very hard gray white mass. It has no mitotic figures. Okay. Sometimes what happens is after this fibroma, patient can also develop the metastasis to the peritoneum and to the pleural cavity. And as a result, you will be having a pleural effusion and the ascites in the patient. Okay.
Yeah.
So a patient having a very solid, hard mass in the ovary, which is white in the color maybe, okay, showing a fibrosis. You perform the histology. You're finding so many fibrosis within the ovary, no mitotic figures. Apart from that, apart from having the mass, patient is also having a ascites and the pleural effusion. You will think about the fibromas, okay?
Yes.
So these are all the tumors, okay? Let's remind ourselves again. You have the epithelial cell tumors, two types of epithelium, serous or the mucinous epithelium. So tumor could be a serous cystadenoma, serous adenocarcinoma, mucinous cystadenoma or mucinous cystadenocarcinoma. Germ cells tumor, which are arise from the ovum. Okay. Patient could be having a yolk sac tumor, patient could be having a dysseminoma, patient could be having a choriocarcinoma, and patient could be having a teratoma. 4 types, okay? Mature, immature teratoma, they could be of 2 types again. Sex cord stromal tumor could be from the trichoma, germ cells tumor from the Leydig cell cytoid tumor from the fibromas also, right? 4 types. So that is a classification and that is all the features of the ovarian cancers. Any doubt, please ask.
When we're talking about the epithelial cell tumors, will they actually be present on the epithelium going into the peritoneal space?
Sorry, I understand. Repeat again, please. Epithelial cell tumor.
So all of these different cell tumors, like they're either on the epithelium, inside the germ cell, inside they're all going to be location based. So they're going to
exactly.
location.
See, they can found anywhere. They can involve the whole ovary. So in the whole ovary, you will find only the epithelial cells if it is arrived from the epithelium, right?
Okay. Okay.
So cells are from the epithelium, but they can be found anywhere, right?
Yeah. Okay.
Yeah, that is the thing. Any more doubt?
Yeah. Thank you.
Okay, so let's wind up here for now. Okay.
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 Thank you so much.
Thank you,
so
sir.
much, everyone.